3 years ago when we met live for the Global Respiratory Summit, there were actually only about 25, 30 of us collectively together in that room. Today we are a larger group than that, as you can see here in this room. Plus we have an additional 25, 30 people online today. So the organization has grown, the participation has accelerated, and it really is just overwhelming to me to take a step back and to think about how far we have come in the last 3 years to be together in this place and all that has happened. And you'll hear throughout the day this common theme of kind of change management and how we view the world today, the opportunity that lies before us. Never before has there been a moment in time where respiratory had the attention of everyone across the globe. Lung health has consumed the headlines for much of the past 2.5 years. And none of us 3 years ago sitting in this room or in the room that we were together, actually in Madrid, could have anticipated what was to come, what was ahead. And yet we have fared that, and we are here on the other side of that in a new normal that we will talk a great deal about today as lung health advocates. And so I am so honored that you have chosen to make the trip to be here with us, to spend this full day looking ahead to 2023, thinking about how we can truly capitalize and optimize this effort, because we will never have a moment in time like the moment we have now. There will never be another, in our lifetimes, another thing. Pray and hope, another global lung health pandemic, right? That the world basically comes to a halt and everyone takes attention and stock in the importance of lung health. So how will we capitalize on that? That's going to be the focus of our time together today. And so as we get started, let's first just take a look about, I said this giant Tanya really sort of freaks me out. I have to tell you guys, because as a 5'2", that's as tall as I am, I think. So anyway, but that's me. This is the agenda for the day and how we'll spend the balance of our time. I will start out with some opening remarks, as well as have some opening remarks from our project manager, Victor Gascon-Marino, and our executive director, Lindsay DeSantis. And then we will go into our first breakout session, which will be by therapeutic area or disease state. So we'll have an asthma table, a COPD table, and a rare disease table to have conversations around how we align on awareness, education, and policy change in the new year. Then we'll come back and we'll share a bit about what we talked about from each group. And then we'll go to lunch. And then we'll have our next breakout session when we return from lunch, which will focus on specifically regional breakouts. And so we'll break out based off of the region of the world by which each of us represent. And then we'll have some discussions about how we might be able to work together and collaborate to accelerate and amplify the patient voice in our own different regions of the world, as well as collectively as a global community. So we'll report back later this afternoon, and then we have a very special wrap-up for the day, a keynote speech by Duncan Stevens, who is the founder and CEO of the Influence Association, on really how we can leverage our influence and why we are better together. We can all go about focusing on the mission of our individual organizations and advancing those missions, and yet we also can work collectively and collaboratively to a greater mission, to create that world without atopic and airways diseases. And that really is our vision and mission at GAAPP, is to create that world where this, at some point in time, is a world where people do not suffer as greatly from these diseases. And then I'll wrap up with some concluding statements, more around where we go from here, how we pull it all together, and what our 2023 looks like as we work together. All right, sounds like a full day, and then we're going to have a delightful dinner. I hope everyone brought their costumes to represent their countries. I did, however, my bag is somewhere between New York and Barcelona. So I'm going to walk over to the mall perhaps this afternoon and find something that might represent the red, white, and blue. I'm not sure. But I had this cute little baseball outfit that I was so excited to wear, and now it's all for naught. We'll see if it arrives. But nonetheless, it's going to be a great dinner, and we'll give more details about that a little later this afternoon. All right, any questions as we get started? Well, as we do get started, I want to say that today would not be possible without the support and help of our sponsors. The Global Respiratory Summit really was a vision of mine to bring our organizations together. About 5-6 years ago was the first time and I went to our industry partners and said, is there any way that you could support this? And so many of those partners stepped up. So AstraZeneca, Sanofi Regeneron, Novartis, Genentech, Roche. It's been so wonderful to see the way that our partner organizations like GSK and others have come together around this table to say there is value in the patient voice, the collective global patient voice. And so as I go through our update and talk about the way the organization has grown, the activity that we've done in the last year, I'll call out various partners and their support for those efforts. But I also want to call them out today because without their support, we would not be able to be here together in Barcelona and represent so many different parts of the world. So again, 3 years ago when we came together, we were a collective umbrella organization representing about 60 patient advocacy groups. And that was total. We've lost some, we've gained even more. And today we stand at 82 member organizations from all around the world. We are actually the same size as the World Patient Alliance, which is all chronic disease areas. So GAAPP alone, as an umbrella organization, is the same size as the World Patient Alliance, which is all chronic conditions. And I think that where we go from here is to continue to grow, to continue to see this map full of red dots all across the world, making sure that every patient voice is represented in the work that we're doing at the Global Allergy and Airways Patient Platform. In 2022 alone, we do have about 20 new members. And so since we were last together virtually at our Global Respiratory Summit, these are the organizations that have joined. You can see that we have had great growth, especially in Central and South America and LATAM, as well as significant growth in Europe, Oceania, as well as Asia and North America. So we're very excited about the way that, again, we're not just reaching into the developed world, we're also reaching into the low to middle income countries and the underdeveloped world and supporting new organizations starting up. I had a conversation this morning, actually, about the potential of a new organization in Belgium. And so these are the kinds of things that really motivate us at GAAPP to continue to do the work that we're doing. Okay. So let me provide kind of a where we are as we come to the last 4 months of 2022. Welcome. Come on in, guys. Good to see you. Welcome. So as we think about, kind of where we are on our objectives for 2022 and how what we've achieved in this first 8 months of the year, a few highlights that I wanted to share with you. First is our awareness days. So you can see here that we have 5 awareness days that we have created and distributed different toolkits. And then we also have participated in 4 additional awareness days where there were resources provided to GAAPP that we disseminated. So in totality, 9 different awareness days in the first 8 months of this year. And that really begins to build that collective patient voice. When all of us utilize and amplify these resources across our social channels, there begins to build momentum and a consistent message that is more impactful to the patient community, to the provider community, and to the policymaker community. And so that's why our work on these awareness days is so very important, because it's a moment in time where we can stand together and share those common, consistent messages. So thank you all for the participation and for participating in those Awareness Day activities. One thing I will say, and Victor's called it out nicely here on this slide, but if you ever need your translation, if you get something from us and you say, yes, but it's in English, and that's not the primary language of my country or region, please let us know. We always try to put it out in at least English and Spanish first. But then if there are other nuances or languages or translations that you would like, if you want us to change the imagery to be more representative of your country, please let us know, because that's what we're here to do, that we're here to support you in that way and make sure that the resources are able to be used in your own respective channels. Next is a couple of current communication grant opportunities that we have for you as members. And these are just around the corner. So we are creeping up on World Atopic Eczema Day, and we have a lovely 80 Caregivers Academy that are videos about what it really is like to live with atopic dermatitis and eczema. And so that will be September 1st through October 14th, where we'll be offering a grant for amplifying these campaigns. And then next is World Lung Day, which of course is September 25th. And here you can see that again, we will have that toolkit and communication grant around that as well. And that is, I think that's a typo there on the 80 caregivers, because this toolkit here is actually focused on access to inhalers in low to middle income countries. So here is a very important topic that we know. Unfortunately, in many low to middle income countries today, an inhaler is more expensive than a month of wages. And so we have 7 videos, right, Victor, 7? Yeah, 7 videos from different country representatives expressing the need for affordable medications in their countries, expressing the concern about having to choose between a roof over their child's head or the necessary life-saving medication to keep them alive. And so a very powerful group of resources that, again, we hope you will commit to disseminating. So again, we work across many therapeutic areas and disease states because we are that umbrella of atopic and airways diseases. And so we split this up as far as our different education and awareness projects by therapeutic area to just give you a high-level overview of all the work that we've been working on in 2022. So in the asthma space, we have the Define Your Asthma campaign, and we'll speak more about that in just a moment. We also have an effort that many of you have participated in called Break Over Reliance. And this is around the overuse of short-acting bronchodilators and albuterol, right? We know that, unfortunately, that is the #1 signal for mortality or death due to asthma. Mortality due to asthma is actually when a patient is using their albuterol too frequently or salbuterol too frequently. So we have a campaign specifically to help people realize that. And then we also have My Asthma Diary, which is a campaign we'll talk about, a project we'll talk about in a moment. And then our asthma adherence and quality of life. And so these, again, there are several initiatives here that have been supported and funded by GSK as well as AstraZeneca. And again, in this asthma space alone. Now, in our atopic dermatitis, we already talked about the Caregivers Academy and the videos, the very helpful videos that are being produced there, and the support that we have received from Global Skin as well as from Sanofi Regeneron on all of our atopic dermatitis work. COPD, we have our COPD and Patient Empowerment Guides, Phase 2, and a project that we have worked so closely with Nicole Huss on, and also our Speak Up for COPD campaign and our Be Flare Aware campaign. And so we'll talk more about those in a moment. But opportunities here that AstraZeneca has really come forth in this work of COPD awareness. So we did a concerted effort about 4 or 5 years ago, for those of you who were members of GAAPP at that time, around severe asthma, and saw the needle move significantly on the greater diagnosis and treatment of individuals living with severe asthma. And now we're taking that same energy and momentum and really focusing in on COPD, because unfortunately it continues to be one of the leading causes, three top leading causes of death across the world. And so there's so much work to be done in the COPD area. In chronic urticaria, that community has grown very rapidly for GAAPP. So we have about 10, 12 organizations that cover that space of urticaria. And we've worked together to do capacity building, to host monthly coffee chats, and to develop a shared decision-making aid in this year alone in that chronic urticaria space. And very thankful for Novartis and the support in the chronic urticaria space, as well as Sanofi Regeneron. Eosinophilic esophagitis, we had our EOE knowledge exchange. So these are eosinophilic-driven diseases like severe asthma, GI diseases, atopic eczema, dermatitis also is an eosinophilic-driven disease much of the time. And so the connection of these diseases and the role of eosinophils really is much greater understanding than where we were even a few years ago. And so this EOE knowledge exchange was a supported effort through Sanofi Regeneron, and also we've had some interaction with GSK in this area as well. And then eosinophil-driven disease, the type 2 inflammation patient navigator. A huge shout out to Mitchell Silva, one of our partners that we worked with to develop this online congress where you can go and very easily begin to understand the connection of all of the type 2 inflammatory diseases, where you can hear patient testimonies, where you can hear providers and the latest science around the understanding of the connection of these diseases. And then a project that we are just now embarking on is a type 2 evidence generation survey project, where we'll be going out to 10 different countries and assessing both healthcare provider and patient perceptions on these diseases. Do doctors and patients understand that connection? Are they, diagnosing them, and are they offering the latest treatments for those patients to address some of the comorbidities that oftentimes arise when you have that type 2 inflammation? And so, again, a lot of different therapeutic areas, a lot of different projects, and I am so incredibly proud of the work that we are doing at GAAPP. We are doing, because this is not Tanya, as much as I love to stand and take the credit and represent you all on the global stage. It is Victor, it's not just the staff, so it's not just Tanya, it's not just the staff of Lindsay and Victor and the team that's working around the clock to really carry out these projects. It is all of us. It takes every single person in this room, every single person in the online community, and even those that couldn't be with us today. It takes patients being willing to be vulnerable, to step forward, to share their experience, and their willingness to say, I can make a difference. This can change. We can close the gap between where care exists today and where it should be in the years to come. So this is a project survey that we were part of that we helped to field on 2022 Asthma in Review. And again, you can see here that this was the patient perspective across 8 different countries, and you can see those countries represented. And here we really looked at the asthma reviews over the last 2 years for those patients. So we know that the pandemic, unfortunately, created some barriers to patients getting the routine care that they needed, right? I don't know about you all, but I know I did. I skipped a few of my annual reviews that I should have gotten during that time. I was very reluctant to go to the ER, to the hospital. It had to be something that I was afraid I was going to die before I would do so because of the risk of COVID, right? And so we wanted to really assess from this survey and from the data how this had impacted standard of care, those standard asthma reviews by patients across the world. So you can see that we had 200 responses from China, 100 from Saudi Arabia, 110 from Mexico, 50 from Australia, 54 from Canada, 105 from France, 108 from the UK, and 235 from the US. And here is what we saw. Not surprisingly, 100% of patients were using SABA. their quick relief medication, right? And that was kind of the go-to in this period. Between 52 and 72% of patients were also using their controller. So again, unfortunately, not that surprising. We know that many, many people rely on quick relief alone and don't use controller medication. And so during this 2-year period of the pandemic, very similar. 69% of all the patients identified with the statement of, I use an inhaler for my asthma, but not regularly. So again, that's a sign that we know that asthma especially is kind of a episodic disease. It's a chronic condition, but it has episodes of worsening symptoms. And so that is what the majority of patients identified there, that they're not taking their medicine except perhaps when they were having an episode or having true recognition of symptoms. So in this 2022 baseline survey, a significant proportion of patients in all 8 countries felt that the main benefits of their asthma inhalers were quick relief and improvement of symptoms, with a minority of them really understanding the reduction of risk in hospitalization. So again, it shows that we still have some work to do, because the latest guidelines, what did the latest GINA guidelines say about this, right? That every time we use a quick relief, we should also use a controller, right? We should always be pairing those two together. And so it shows that we definitely have some work to do to get to true guidelines-based global approaches. And so again, that bottom line of just the fact that patients do prefer their quick relief because it gives them that perception of symptom relief. And then that it leads to the paradox of that 38 to 65% of patients over-relying on their rescue and also over-relying on oral corticosteroids. And so when we talk about our various projects and other initiatives, you'll hear me talk about steroid stewardship, systemic steroid stewardship, oral corticosteroid stewardship. And that is because we know now the data has evolved so rapidly in the last 2 or 3 years, the harm that is done to patients when they are on systemic steroids over time. 4 courses of steroids, systemic steroids, in a lifetime increases your risk for diabetes, heart disease, osteoporosis. Only 4 bursts of systemic steroids. So this is a real concern and effort and priority at GAAPP to address steroid stewardship. So now I'm going to ask Victor to join me in kind of going through some of the different projects in a little bit more detail. If you haven't met Victor, most of you have, that Victor Gascon-Marino, our project manager in all things, just our go-to guy for everything. Maybe stand up, I think it'll be easier.
Yeah, well, I have a paper now, you call me out.
Can we get it?
Hello?
Yeah.
Yeah, so I just want to give you a quick brief of 3 projects that we have currently developed. This is the second phase of the Define Your Asthma campaign. We did the first phase in 2021. In this phase, we focus on the importance of the role of the caregivers to make sure that caregivers and family members, to make sure that you get that support that you need to make sure you go to the doctor on time, that you take care of your asthma. And how important is that? Like we have this testimonial from Thu Pham from Vietnam. Her testimony is very touching because she couldn't take care of her children because of her severe asthma attacks. Next one. This is also a project from Vietnam. This is our COPD patient empowerment guides. We have just translated them into Vietnamese. So if anyone else from this room wants these guides in your own language, just let us know. This is my asthma diary project. This is a project that we have testimonials from Iranzu here, from Spain, Brenda from the US, and Christian from Nigeria that is online. So these are testimonials that we have developed to present healthcare professionals and medical teams the important in the patient's perspective on living with severe asthma and the challenges that patients have over the world. Next one. So this is also another GSK project. This is managing your asthma. This project will come live tomorrow. This project is based on the importance of managing your asthma, the adherence, and the regular visit to your doctor if you need. That is something that we have forget with the pandemic, right? As Tonya was saying. So this project will be live tomorrow for the GRS.
Great.
And I think that's all. Yeah.
Yeah. Thank you,
Tonya.
Victor. Also, we want to call attention to the Speak Up for COPD campaign. Now, this is a collaborative campaign that we are leading alongside Chiesi, International Federation on Aging, and AstraZeneca. I'm really excited about this partnership and the effort, as I was saying before, about elevating COPD in the policy priority conversations. And, you know, what we know, again, is that it's the third biggest killer globally. And yet it is under-recognized, under-resourced, universally. Even in very developed, high-resource countries, COPD does not get the fair share of that attention or funding. And so we know that now is the time that we really help to make this, if we can collectively work together to help make this a public health priority, that, again, many even of our long COVID patients that we're hearing from, patients that are having respiratory issues months and months out from acute infection of COVID, are going to be classified as COPD. Right, wrong, or indifferent. That's because the long COVID classification is really not that well defined today. And so many of these patients, because of their loss in lung function, their irreversibility, are going to be labeled as COPD. And again, that is tens of millions of patients around the world that are currently living with those symptoms. The other reason I'm so excited about this particular campaign is because of the partnership with International Federation on Aging. And, you know, this is an international group similar to GAAPP, but who focuses specifically on conditions that are impacting our senior adult populations across the world. And a very powerful organization with a very strong leader who has recognized that in that senior adult population, COPD really, again, has been underrepresented or undervalued. And so I think it's a nice opportunity for us to work with other disease state or other larger umbrella organizations that are focused on broader disease states, not just respiratory, right? That even in larger circles, they're recognizing the importance of respiratory health. I want to say just a couple of things. I know we're right at time for our first session, but I want to say a couple of things about other advocacy issues that are ongoing. One is the F-gas regulations that are being discussed in the EU, in the European Parliament. GAAPP did make the decision to put in a comment on this regulation, and the reason we did so is because greater than 70% of all inhalers across the world globally, 70% of inhalers are manufactured in the EU. So whatever happens to inhaler manufacturing in the EU impacts everyone. Impacts Isaac in Kenya, impacts my community in the US, impacts, Mitchell's community in Belgium. And so we have to be cognizant of the global impact, and that's why GAAPP chose to speak out here. We are all about taking care of the climate. Trust me, you will never hear me talk about or diminish the importance of taking care of our Earth and the climate. However, currently, MDIs only account for 2%, less than 2% of the emissions. And the aggressive regulatory stance the EU is taking would put many, many patients at risk for not having an inhaler, especially in those low to middle income countries. So that's why we felt we had to speak up and step out and ask the EU to actually reconsider their timeline, to give more time to the inhaler manufacturers to come up with alternatives that are safer for the emissions, okay? And so, again, if you want to know more, we've got the statement over here, as well as some of the Speak Up materials and other resources from GAAPP, also at this QR code or this link. Or if you want to talk with me about it even more, I'd love to chat more about our stance here and how sustainability is a priority for GAAPP, but we cannot be so concerned about the environment tomorrow that we put patients at risk today. We have to have the balance of both, of taking care of patient outcomes today, making sure patients have access to those essential medications. So some of the other projects that you'll hear about as we talk in our breakout groups, and also here at the Congress. Number one, a really important effort that was led by the COPD Foundation and Kristen Willard's group here out of the U.S. on a tobacco industry survey that many of you participated in and helped us to disseminate. We have insight from all over the world about how patients feel about tobacco companies buying pharmaceutical companies and offering pharmaceutical products for conditions that they basically created in many cases, right? And so that publication, those presentations will be at the ERS, and it was released in Thorax, the peer-reviewed journal. The OCS stewardship, I've already talked a good bit about this, but again, having consistent messages around no more than 2 bursts in 12 months of OCS, no more than 4 bursts in a lifetime, because that is the point where, honestly, we should be looking at other alternative treatments. The GINA guidelines say last resort, systemic steroids last resort, and we need to move physician behavior and patient behavior to that point as well. We are participating in the WHO GARD, which is the Global Alliance for Respiratory Disease, and speaking at the World Health Summit that is coming up in October in Berlin. And so this is a WHO-hosted event. And what I can tell you is that the relationship with WHO and GAAPP has never been stronger. Sarah Rylance is the point person at WHO who is over all respiratory disease. She and I speak on a monthly basis. We are constantly talking about how GAAPP can play that central role in representing the patient voice in the respiratory community at WHO. So, thank you. Again, the guidelines. So we know that guidelines are not perfect, but they are what we have as far as standard of care. And thankfully, we have involvement and a voice on both GINA and GOLD. So the GINA asthma guidelines and the GOLD COPD guidelines. As a patient advocate reviewer, I have, again, ongoing conversations with these scientific committees about what does this really mean for patients? And should we be updating these to really be more reflective of the unmet needs for patients and the latest science? And so, again, even the OCS as a last resort language came out of conversations that we were driving several years ago. The change to SABA plus controller and the consideration of the term mild asthma evolved out of conversations that we were a part of, that Peter and others were a part of. So very thankful for our role and influence in participating in the GINA and GOLD guidelines updates. And then the type 2 evidence generation project that I talked about before. So publications, really quickly as we close in this session, we now have over 50 peer-reviewed publications that you and I are co-authors on. So we have now a library where the patient voice is coming forward in things like patient charters and quality standards and shared decision making. There are so many different articles that if you look up on this particular place, you can see all the different publications that the patient voice is more evident. Again, 5 years ago, I was begging someone to put a patient on an author group to get into peer-reviewed literature. Today, over 50 publications later. And that, again, is just the power of the global patient voice. And so very proud of the work that's been done here. A couple of coalitions that we're working on. The Respiratory Right Care Summit was held last fall, and it really then laid the foundation and the evolution of what was launched in 2022, which is the International Respiratory Coalition. And so this is a coalition that is multi-funded, is led by ERS and GAAPP. So the European Respiratory Society and GAAPP are the leaders of the IRC. And again, GSK, Chiesi, AstraZeneca, all a part of this effort in moving respiratory policy forward. So it's a very policy focus. It's how do we get respiratory prioritized. And you'll hear more about this if you are at the ERS. We have 3 different symposiums, and we're also launching a resource called Lung Facts, which really looks in depth into each country. Like you can pull out the lung facts for your country and create almost like a report card of how your country stacks up to other countries when it comes to respiratory policy. And so this will be very, very helpful in having discussions with legislators, with lawmakers. A few things on the board and the staff, just quickly. Everyone who has been around GAAPP knows Otto Sprenger. He has been a founder of the organization as well as our treasurer for many years, since 2009 when the organization started. And Otto is very well-deserved retiring in 2022. He is not with us today here in person, recovering from hip replacement, and so we wish Otto well. He will be leaving at the end of the year, and we did honor him with a Founders Award 3 years ago when we were together, but I know that you all will want to join me in just giving a round of applause for Otto and his years of contribution to GAAPP. Vanessa Foran, who has served as the secretary of GAAPP, is actually resigning her role with Asthma Canada, taking on a new role. And so we will have 2 board appointees. So our bylaws say that we must appoint board members rather than in a midterm. So we, as the board, Christine Warlow, Ashok Gupta, and myself will appoint 2 new board members, one in October to fill Vanessa's role through June, and then a second in January to fill the vice treasurer role as Ashok steps into the treasurer role in January. And then in June of so the reason I bring that up is because you may be the lucky one that we come to and ask, or if you're interested, please step forward. No, it's that voluntold versus volunteer sort of thing here. If you are interested in serving on GAAPP's board, please step forward. Let's have a conversation about what that entails. And we are trying to make sure that the board is fully representative of every region throughout the world. So that will be our intent, is to make sure that any board member that we recruit to come on is giving a unique perspective. So everything is not, North America or Europe, a certain region. But that is the board updates. Staff updates, Lindsay DeSantis is our executive director. I think everyone's met Lindsay, but if not, she is here, and we're very excited to have her join us as of March of 2022. So, and then staff updates, again, this is our current staff. We do have a social media consultant that we're using for most of our work across our social channels, Rapson, and it's going extremely well. I was overhearing, eavesdropping on a conversation this morning about how quickly the followers are growing across different channels, and so really excited about that relationship. And then Peter Schweikert continues to help us in developing Asia Pacific as a consultant. So this is the staff. It's a small group. I mean, you guys see, right? We don't have a lot of human resources and capital, and yet we're doing such amazing work through that full-time team and the volunteer efforts of each of us in the room. So now we are going to go right into our first breakout session, which is on the asthma, COPD, and rare diseases. And the way this is going to work, because we do have some people online and some people in the room, is we're going to ask you to congregate in one of 3 corners. So if you want asthma to be your primary focus, then you will join me in the back of the room back here. If you want COPD to be your primary focus for the purpose of this exercise, then you'll join up here with Lindsay. And then if you want the rare lung disease, rare disease area, you'll join Victor here, yeah? And we really want to focus this time on 3 key discussions, okay? So we could easily get stuck on all of the unmet needs, on all of the barriers, on all of the challenges. We know these, right? We live this every day. We hear this from patients every day. We don't want to get stuck there, okay? We want to bring some of those things out, but really try to focus in on what is the single message that if we could get the world to know, as far as just awareness about the disease, would truly make a difference. What is that single message? So this is sort of challenging, especially I think for those of you in the rare disease, because it's kind of putting your own disease focus maybe a little bit to the side and thinking collectively. If we had a single awareness message, what would that be? Okay? Then the second is the priority unmet need or message in disease education. So awareness, education. If you could only create one education program, tool, resource in the next year, what would that be? We don't want to recreate the wheel. So if it's already out there, if somebody says, no, I've seen that, we have to take that one off, okay? So we really want to think about what is something that doesn't exist today that will fill an unmet need or gap in that development space of an education initiative. And then what is the one policy change? And not everyone in the room, I know this, not everyone in the room works in that policy realm, right? You don't work in, you don't deal with government officials and things like that. But I want you to come into that conversation imagining that you did. Imagining that you felt confident and that you were skilled to have those conversations with lawmakers. What would be that one ask? If you were sitting before your MEP or your, legislator, the president, whoever of your healthcare system, what would you ask for? Okay? So those are the three things we're going to discuss in our breakouts. Victor, do you need to say anything perhaps in Spanish since we have a large contingency in Spanish that may help to clarify what I said? And I promise I am listening to Babel every night trying to learn more Spanish. I really am, every night.
Hola a todos los que habláis castellano, todos los que estáis online, pues tenéis que elegir vuestro grupo, vuestra sesión. Podéis elegir entre asma, APAC o enfermedades raras. Y los que estamos aquí presentes nos distribuiremos en mesas para también hacer los grupos. Enfermedades raras estarán al fondo. Asma is here. APAC aquí y asma al final.
Okay, so we have about 30 minutes to go into our breakouts and to have this conversation, and then we'll come back. Yes. If someone is interested in 2, then. Yeah, so if you are divided, if your affections are split, I understand because I'm in the same boat. What I would say is that perhaps you go to the COPD if you are split between 2, because that seems to be the smaller group today. So go to COPD if you are split, and that is one of them. Otherwise, choose the one that you work in the majority of the time. Okay? Okay, so asthma in this corner, COPD in this corner, rare disease in this corner. For those of you online, we'll be joining you in the breakout sessions in just a moment. Thank you. We do have a few people online that are joining us. So what I'm going to ask is that you raise your hand using the button if you want to speak up or add in for those that are online, okay? What I will say is I will apologize now for those that are online only, that perhaps you didn't get to actively participate in that breakout as readily as we would have liked. What I will tell you is that in the asthma group, we had some chatting going on in the chat. We're going to just take this and summarize and send it back to you all. So this is not set in stone. This is something that we're going to circulate, get your feedback on after this meeting. So your opportunity to weigh in is not only today, okay? So don't get anxious that we set the whole year in motion in 30 minutes. That was not the plan. Ready, just another minute or two to grab a drink. Yes, I'm good, thank you. Can you see if they can either close that or crank the air because it's hot? All right, everybody, if you'll take your seats, we're going to have our readouts from each group. This is what stands between you and lunch. So I know everybody wants to get their lunch on time. We don't want to cut lunch short. What time is it now, Victor?
It's exactly 1:30.
Okay. Okay, everyone. So we are going to give each group 10 minutes to summarize and report out what your group discussed. Okay, so each group has 10 minutes to do that. I know that was fast and furious. This is going to be fast and furious. What I was saying, in case you didn't hear, this is not set in stone. So what we will do after this meeting, we'll send this out for your feedback, for kind of, making sure that we're on the right track and all aligned, and then the tactics associated with this. This really is you weighing in to the board of directors so that then we can go back and craft more specific actions and strategies. We have a strategic planning session coming up. And so we needed to hear from you about if you could prioritize what would that be in these areas, and this is going to be super helpful. So with that, let's start out with our rare disease group. Victor's on the clock for 10 minutes.
Okay. Okay, so for the rare disease group, we have 3 key messages for each of the main points of awareness, policy, and healthcare professional. Sorry? Oh, yes. Yeah, I have like a doctor calligraphy, so you probably won't understand. Okay, so the first message, awareness message is saying having a rare disease doesn't exclude me from having human rights, and we should fight for the quality of life and the inclusivity of the patients. That's the first message of awareness. The second message is centered on the importance of getting access to access to innovative systems, and the lack of reimbursement that some countries has for rare disease medication and treatment. And the third message is centered on, this is more like an advocacy message, saying not every disability is feasible, and we have to fight the age misrepresentation that we have in our awareness campaigns. We were getting COPD as an example, that we always have like a more aged person for advocacy purpose on COPD, and as we know with Elena, COPD can also affect young people and have a genetic factor. So that's also happened with rare disease. So the next block is about policy. The first message is like we need to improve the access to treatment in low-income countries, especially. That's a global issue, but it's really terrible in low-income countries, that we should do something about it. Then the second message is regarding the registries. So it's that every country should develop a registry supported by patient advocacy groups and doctors, encouraging patients to join those registries. And they should be more patient-centric. And then the third, like also regarding registries, we have some countries where scientific societies and governments have separate registries. So we should create awareness for those to join forces somehow, even though we know it's difficult data-wise, right? So the third message on policy is also access to innovative systems. So now the third block is regarding the education for healthcare professionals and patients. So we also have 3 messages. The first message is primary care doctors and pediatricians. They should have developed programs for and improve screening tools. We also should introduce rare diseases in the curriculum, in the doctor's curriculum when they study the undergraduate, somehow as an extra, or somehow rare diseases should be introduced, because as Dr. Ashok was saying, most of the doctors, when they graduate, they have very little knowledge on rare diseases. The second message is centered on the scientific societies, that they should be also the same message as in policy. The scientific societies should be more patient-centric, also especially in low-income countries, which that disconnect is more visible. And then we have another message on we shouldn't talk about this is only for healthcare professional education. When we communicate with healthcare professionals, we shouldn't say rare disease as in general. We should focus on each specific disease, because we cannot put in a basket all the rare diseases that exist when we try to educate healthcare professionals on the challenges.
Just one clarifying question about that. So oftentimes when we're talking to policymakers about rare disease, we try to bucket it so that it looks like a bigger population, because the more voters, quite honestly, the more voters it impacts, the more they care about it, right? But what I hear the rare disease group here saying is that that may be fine in that with those conversations, but in the education, we need to be more specific and not, right? Is that what I'm hearing?
Yeah.
Okay.
So we should,
super helpful.
In awareness and advocacy, and as in general, we should continue talking about rare diseases to try to, number up and have a bigger population. As you say, very important for policymakers, but when it comes to us educating or informating is not a word.
Informing.
You
got it.
Healthcare professionals, we should try to not sum up.
Yeah. Okay.
No, the point is rare disease is now an accepted terminology. It's almost like a developing super specialty. So putting something else will not give the right message, one. Number two, the interest of the group was to focus on treatable rare diseases for which you have currently available treatment. So every year, what Victor rightly said was we would like to focus on developing at least focus on one or two rare disease whose treatment is available, and then creating awareness amongst the patient group so that across the world, these patients get the right treatment. So that's the thought that we had in the group. And I think we will not be in a position to change any terms.
My only answer is, all the things that start from a seed. You start doing, she started doing 5 years ago, and now it's quite a big tree at the moment. So all the things that start from somewhere. So some people think, and then they start telling the others. So although somebody has done it, given a name rare. So if you give another name, you can talk to the people, and hopefully, if you feel like that it is, if you are committed that this word is better, then I think we can start with it.
Thank you, Dr. Gulam. And sorry, my last message for healthcare professional education is some message that makes me very happy, because the group say we should translate medical and scientific medical guidelines in scientific papers to patient-friendly language, and it's something that we are doing right now with APAC. So this message makes me happy to see we are going in the right direction.
Yes, such a need. Thank you, Group 1 for Rare Disease. Great job. That's what a Lindsay.
Oh, yes. Sorry.
All right. Oh, okay. Lindsay's already got hers. We're going to go to the COPD group next.
All right. So what we identified in the group was really coming up with who is the patient, what is the profile, and really it's not only smokers, it's not only for older individuals, and really the idea of it could be you, and knowing
A little closer.
knowing your lungs.
Thanks.
And how, it's underdiagnosed, and really driving forth the statistics that it's not curable, the difference between asthma and COPD, and that is the third cause of death, and the cost of that. And so when we really went through for the patient messages, intervention and communicating with your provider, as well as addressing the stigma. And there was a lot of discussion about addressing the stigma first, because Empowerment comes after you have really understood the disease itself. And where we had a lot of discussion about was understanding the symptoms and being able to communicate that with providers and having education around spirometry and how important that is in diagnosis. And as we discussed, that was a key policy change, mandating screening and spirometry and increasing accessibility to that, whether that is beyond your general practitioner, if that's within pharmacies and other areas. And that would be a key policy change, is that early identification of the disease that then decreases the burden of cost for treatment as the disease progresses. And so that would be the key messages. It would be understanding your lungs, and I think Nicole said it best. People focus a lot on heart, but know your lungs and how important lungs are, and if something isn't right. If you have never been a smoker, it doesn't mean that you're not going to get COPD. And I think that is something that is an important message to share with the general public and for the patients to better understand what the disease means and what those interventions are. That if caught early, there are a lot of interventions where you can live a fruitful life, and really designing a campaign around that: early screening, mandated screening, better communication with healthcare providers, and that education for the patient to know what spirometry is. And I think that's a very first step. And I think we did talk that some of that screening is very old and it has not been updated, but it's still not utilized on a regular basis.
Great.
Did I miss anything, team?
COPD group, any feedback from that team? Because we do have something, yeah.
Can I add a little smile? We organized the World Lung Day, and there we proposed the quiz, amazing quiz for respiratory health, and we had a question: what does the acronym COPD means? The possibilities: cat, oxygen, Peter's devil. The second, courage, only patient deal. 3, chronic obstructive pulmonary disease. The fourth, conflict, oxygen, possibility, diffusion. Nobody, it was in the center of Paris. 4 hours we posed the questionnaire, and nobody said what it was COPD.
Wow.
I think it was 200, 300 people. So it's very actual, and if you want, I can share our amazing questionnaire for World Lung Day.
Yeah, it's a great point, Ilya, that just the terminology of COPD doesn't necessarily translate globally. Many languages, many countries, there is not a term. You simply cannot translate COPD as that term. But then even where you can, the recognition of what does that really mean is fairly low. So I think from an awareness perspective, that's like square one, right? That we have to find. I don't think we're going to ever rename the term. So let's put that conversation aside, because the literature, because of there's no chance that we ever do that. But is there a way that we could just drive awareness of what that disease is and create some assets? I think is a great point. Gundula, yes, yeah. I'm going to ask you to take the mic, please. And if you will, when you speak, just say your name and what organization you're from, so everybody knows.
Gundula Kobelmiller from the Austrian Lung Union. I think that's very important to think about what really needs to be done first, because as Liliana also said, and what we also did in Austria, we evaluated the status quo, and you have to do that in your country, otherwise you don't know where to start from. Yeah. In Austria, for example, we did evaluate the 6 principles of the COPD patient charter, and we figured out that people know what COPD is, the majority, but what is not working in Austria is the early diagnosis. So the early screening to prevent deterioration and to keep up the life quality is important. On the other hand, what we really miss is the individual treatment plan, including the rehabilitation, including the smoking cessation, including treatment for depression and so on. And the other one is to check your treatment plan after an exacerbation. That's the 3 major issues in Austria, but what I wanted to say is you really have to evaluate first before you go into operation, because you need to really be on the point. Otherwise you miss you just miss time, and it just takes too long. So, but I think it's important to early diagnosis.
Yeah.
And I know there is a program, maybe Peter, you know more about it in Australia, because they say we want to have the smoke-free generation in 2030.
Finland has a
Finland.
amazing program. Of course, their taxation on tobacco is like $20 a pack. So that's why no one smokes in Finland, is because of the, yeah. Very, very heavy. Yeah, Lauren. And Lauren, say name and organization.
Lauren Dunlap for ADA. You mentioned mandated screening. What would that look like? Because in the U.S., that would be a reimbursement issue, more than likely.
Shane? Ask Shane to respond.
There's already validated screeners which exist, and they've already been taken on apps and so on, but they're not really used apart from that. So nowadays we have this amazing way of gathering information very easily with people. So even those screener tests, I think, need to be updated, because they're not giving enough early information about each person's circumstance. It's all very well answering something, but are you living or working in an atmosphere where you're exposed to smoke? So it's not necessary that you're a smoker, et cetera, et cetera. So it's not difficult to add on more information now. Let's not talking about validating it, although it will be another 10 years, right?
Yeah,
So-
Shane, to your point, I mean, we, in the U.S., we use the Capture tool in community-based screening. It's a validated COPD screening tool. It's 5 questions, and it does have a good baseline. And we've screened 5,000 people in the past 2 years with that tool. And then those that are high risk, we do additional additional layers of screening with spirometry and support. And so, a more detailed questionnaire. So I think there are ways. I just don't think that right now, and we're going to talk about it in ours, there's even a national plan for COPD in most places that, would have that as a priority. And to me, that's a starting point. I mean, and when we talk about policy priorities, how many of your countries have a COPD plan?
Spain has one.
Just a plan. I'm just asking a plan, not a good plan, because they all could be improved. But how many even have a plan? 3, 4 in the room. 5, 4, because 4. 4 countries in this room even have a COPD plan. Yes, that's approved by the government as an action plan to go and address this issue. So that, to me, is a fundamental miss, right? That we don't even have the attention of the government or the health, system to prioritize this, right? Okay, I'm going to go to the asthma group, and we're going to give our readout and then break for lunch. So in our group, we had on the awareness, we had some discussion about who is our target audience. We started out thinking maybe public, the general public. Then we talked about healthcare providers, especially primary care. But ultimately, we said the largest unmet need right now is the undiagnosed and undertreated patient community. So that's where we decided to focus our awareness message for 2023. Ultimately, we also had a lot of discussion around valuing breath and breathe with the soul and breathing is a blessing. But all of these came down to 2 things. Number one, breathlessness is not normal, right? So again, at this point in time, we all can take a deep breath and be grateful if we don't have breathlessness, right? But if we sort of got people's attention around breathlessness is not normal in the general population and not taking breath for granted. So those were the two key messages in that undiagnosed and undertreated population. Then when we talked about an education program or initiative, we built on that and we thought, okay, that education program and initiative really then needs to be devoted to patients and primary care providers. We had a lot of discussion around words that we use that don't mean anything to patients. Words like control, words like inflammation. Those are medical words and words that we as a community perhaps have used for decades, and yet does it really resonate with patients? So we talked about how can we rework some of these, and then what are the tools that we could use to help people better recognize their symptoms. Ultimately, we kind of came back to the point of number one, the need for screening and for better screening and early diagnosis, but also this over-reliance theme. Over-reliance on short-acting bronchodilators alone, over-reliance on oral systemic steroids, and then also the over-reliance on people's own comfort level with breathlessness. So we know that most patients normalize, adapt, and don't perceive their own symptoms, right? So that's a degree of over-reliance as well, according to our group. And then also that so many patients are unaware or undereducated about what good care would look like. So things like our charters, things like our quality standards, those all could go into an education toolkit that would include like short videos about what are the harms of over-reliance, short social memes and posts about the harms of over-reliance, and then checklists to determine, are you actually in that category, right? Things like our Pulsar checklist, for those of you who have been around a while, in severe asthma, the ACT, the AirQ, the reliever reliance test. Those are all great tools, but maybe they just need to be sort of in the context of a toolkit that focuses more on the harms of over-reliance. So that is our thought on an education initiative for 2023. And then policy priority, we had a lot of discussion here in a very short period of time because we thought about at the global level, number one, the WHO currently has SABA alone on its PIN list, right? So we need to get that removed. That's one global strategy. But then we had a lot of discussion around, should it be focused on climate, workforce development, because we know that there aren't enough nurses and doctors and respiratory therapists and the workforce issues that the pandemic has really shone a spotlight on. Then we talked about prioritization and why isn't it like cancer, heart, and lung? Why when we talk about the major things that are health, cancer, heart, lung, like it should be that same level of priority. And ultimately, we came down to the one policy focus or change. We want to see a national asthma action plan, a national asthma plan, or lung plan that includes asthma, COPD, and lung. It could have strategies like a registry. It could have strategies like spirometry and early screening. It could have strategies around climate and pollution or workforce development, but also things like funding of research and creating pharmacy or electronic medical record flags. So we thought that number one, again, I'll do the show of hands. How many of your countries have national asthma action plans, national asthma plans today? The U.S. does. So I see 3 different countries, 4 maybe. Yeah. So 4, again, only 4 countries and different than the COPD. So so you're saying your professional society has the pediatrician professional society, but we're saying how do we get the government to really take this to a priority level? And we think that the ask we could make as a community is that every country has a national action plan. And then the tactics may look different, right? The tactics in Australia are likely to be very different than the tactics that I would advocate for in the US. But I think that there will be a lot of similarities, and we could probably offer 10 to 15 different strategies that would, you could pick and choose, if you will. Yeah, Peter.
Yeah, I was going to say.
Sorry, where's I need your mic. I need your mic. The people online can't hear.
I think the prioritization issue up against cancer, heart, etc., is a challenge, because the reality is, the problem is,
Check.
the governments and a lot of other people think that asthma is sorted. Okay? But going up against cancer and heart is a tough ask, because, quite honestly, asthma doesn't kill anywhere near as many people as heart disease does. But it's not sorted. The difference being is asthma, almost every one of those deaths is preventable. And it's 2022. So if you can prevent it, and you could have prevented it for the last 2 decades, why haven't we? And that's what I think is the message, which is, don't try to compare to cancer, which is only now advancing towards being able to be dealt with. We've been able to deal with asthma for 20 years, but we haven't done it. And that, I think, is a stronger message to governments, which is, you're behind the times. You need to get in front of the times.
Yeah, I appreciate that clarification, Peter, because I don't necessarily think we need to compete with cancer and heart. I mean, those are all very worthwhile priorities, right, that are killing many, many people every year. But it is, how do we make sure that when we talk about the top 3, that lung is there? And I also think that one way we do that is not making it just about asthma, but including COPD, because, again, we know it's the 3rd leading cause of mortality globally. So I think that if we talk about lung as a broader term, we'll also get greater attention by those policymakers. Nicole, yes, you were going to say something? Oh, okay, I thought your hand was up. I'm sorry. Anyone else have questions or comments about the asthma group report? All right, well, I think that was a very, very productive exercise. I really appreciate everybody's feedback. Again, this will be so helpful to us as the board. We'll go back, put some thoughts and further strategies around this, and then come back to you all to get that, approved as the direction for the new year. But very, very helpful in aligning and hopefully also getting your creative thoughts and juices flowing about your plans for your in-country activities in 2023. Okay, it is noon, and so we are going to go for lunch. And Victor, you want to give us instructions on where we're going, what we're doing, or Lindsay?
We're going to go right around the restaurant. It's outside on the terrace. Lunch is already available, so you'll just go around. I think that they might be closed off straight down the hall. Oh, when you come out, just take a left.
So take a left, go right outside on the terrace. We'll have lunch. We'll be back in 1 hour. For those of you online, we will see you back in an hour. I'm not sure if you're eating breakfast, lunch, or dinner, depending on where you are in the world, but enjoy, and we will see you back in an hour. Okay, welcome everyone. So let me give a little bit of instruction before we begin. So again, if you are in the room and at a table, this is our European table here. This is our North America table here. Here in the center is our Africa, Asia Pacific group, our Balkan sub-region, and then Ibero-America up here, okay? So here's how we're going to run. Guys, listen please. So we have 45 minutes for this part of the program, and we are going to spend our time in these 3 areas. So number one, I want you to think about a cross disease state. So now you're not in your disease state. You're not in your disease state mindset. We're going a little bit higher to your regional mindset. All lung health, okay? Lung and immunology. The biggest challenge for airways, atopic, and allergic disease. Okay, so for the umbrella, the biggest challenge in your region of the world. So I want you to spend about 10 minutes on that, brainstorming, jotting down all those challenges. Then we're going to go for about 10 minutes on proposals to overcome those challenges. Like what are opportunities or ways that we might address those challenges. Okay? And then we'll spend the last 10 minutes on identification of possible alliances, collaborations, cooperations, how we could work together. Okay? So we're going to go from the high level of looking at problems and challenges to then solutions, to then coalitions, cooperations, proposals of working together. Okay? Everybody got the assignment here over the next 30 to 45. Okay? Great. Well, then we will dive back in. If you are in an online community, we will get you to where you need to go here in just a moment, and hopefully all the sound will get, but remember the chat function if you are in that online audience. All right. I will be the timekeeper, let you guys know when it is time to move on. 1:05, so at 1:20 we should be moving, 1:15, 1:20, moving into the next one. All right. Thanks. Wonderful work that's being done, but I think that it is time for us to go back to our readouts. All right, so we will have about 8 minutes per group, 8 minutes per region, and we are going to start. Sorry, everybody, if I could get your attention. So we are going to start here in the Europe region with Lindsay leading that group.
Okay.
Shh, shh, shh. Victor and all his beautiful women is what it is. All right, so each group has about 8 minutes to report back to the collective larger room. And we're going to start with Europe.
All right. So some regional challenges that were identified is understanding the impact and the importance of respiratory health. And as seen with COVID, the sufficient medical care that's needed and the lack of access to that care. We highlighted the psychological support and how important that is as part of a treatment or action plan, and that's something that's missing and needs to really start at education at the school level, and understanding the lung health and overall health at that level. And to train the patient to demand more from their healthcare providers. One thing that came up a lot, oh, I'm echoing.
The feedback on that. Yep.
There we go. Hello? Okay, better. One thing that came up a lot was the ERS conference itself as not having the patient voice and how critically important it is to bring the patient voice together in a unified community, and how that's very limiting. And so if you have a global meeting, even if you're within a country that has some confines of patient involvement, there should be some understanding that it's a global meeting and the patient needs to have more of a voice. Although it did also come up that sometimes that also is not financially possible for a patient to attend some of the larger meetings. So overall, there was some of the ideas, project-based work was regulations and creating criteria for the patient versus the patient representative to identify those roles, and the patient organization as part of the healthcare system and receiving that recognition, and defining that criteria. And it was also noted, instead of focusing on regional alliances, because this is about a global policy, really focusing at the national level versus a regional level for some of this work. And if I have missed anything that our group, if I have not captured everything, please feel free to.
Okay, great. Any questions or comments for the Europe group? Okay, all right. I am going to ask Victor to go next with the largest group in the room.
Okay, yeah. So this is the Ibero-American group. It contains people from Spain, Venezuela, Brazil, Colombia. Yeah. So first we will focus, we have detected 8 main challenges that they are equal because we have 2 very different regions like Spain, European country, and Latin America. Mm-hmm. There is a lot of difference, but we have identified 8 common factors that can be applied for the whole Spanish-speaking and Portuguese-speaking region of the world. So first is the lack of services, the lack of access to treatment. Mm-hmm. Third is the lack of early diagnosis, which I think is a global problem, but again, in developing countries is more challenging. The short time that the patients have with the healthcare profession, with doctors, with nurses, and specialists. That's especially in Latin America, that seems to be like a very big problem. They only have 5 minutes. I think in Spain too we have 5 minutes, but sometimes they're more flexible. Though we also have lack of access to GINA and GOLD guidelines to healthcare professionals in Latin America. One of the problems that, this is a different one, is that there is a lack of humanization of the treatments. And that needs to be improved, and from the university level, from the moment that the doctors are being formed in university. We also have the lack of derivation from primary care to specialists. That's something seems to be a concern also, especially in Latin America. And I didn't miss anything, right? Okay, then.
I mean, you have very beautifully, very nicely, you have enumerated all the points, and there are many problems. But the question was that was put up was the biggest challenge. So did you identify the biggest challenge?
So yeah, so we cannot identify any of the 8 problems, like one to be more important than the others. Yeah.
Yeah.
Yeah, no. So the 8 problems they have, they're equally important, and they cannot pinpoint one that is more important than the other. So sorry, we cannot give you one answer on that. So and now we will focus on the solution part. So one of the solutions that we identify is teaching medical students and educate them on the existing guidelines and protocols that they are already existing in Europe or in the US, and then we can easily adapt for Latin America. The education on health issues in schools for children from 6 to 8, from 8 to 13, and 13 above. That's also very important. Health in general, not only respiratory or allergy health. Then the screening and the genetic marking, especially of babies or newborns, that's something that they have been identified in Latin America for rare diseases that is lacking and could solve many of these challenges above. And then the promotion of something that I think is uniquely for our region. They are called the patient schools, School of Patients, which is their kind of like organizations for patients that sharing resources, which I think is also shared with the healthcare professionals and the societies. So the promotion of those patient schools it has been detected as a possible solution. And the final solution for the rural access the rural access to treatment, and medicine in general, by empowering patients, empowering healthcare professionals, by a biggest, wider implementation of digital health for those underdeveloped areas or with difficult transport options, and of course increase transport options for rural areas that are not connected to a hospital or a clinical center, or they don't have any access to healthcare professionals. And as a joint actions to try to tackle these problems, we have identified first that we should share the resources from Spain to Latin America, since I think Spain organizations have more access to educational resources and tools that they could be easily shared in Latin America, since they are in the same language.
Yeah.
Also sharing educational tools. Spain organizations to try to be more involved in Latin America, if possible, with the resources that you have now. Try to join each other's events and initiatives in every Spanish and Portuguese speaking organizations. Working in committees interest committees by disease state. That's also in kind of informal groups. And develop a library of good practices in Spanish and Portuguese for the region.
Great.
Yeah, that's
Great.
a lot.
Great. And did we talk about any specific alliance? I mean, I know we have already somewhat formed an alliance in LATAM, but other thoughts around an alliance and how it could work for this subset?
So we have created a live alliance, and we're going to.
We're committed to.
A WhatsApp group has been created already to do.
So, laughingly, Victor says this, but it's one of the things that we do hope comes out of today. Historically, we have aligned by therapeutic area and disease areas that we work on. And that's all well, good, and fine, but we also think that there's some benefit to us working more from a regional perspective and across therapeutic areas. So that is really in jest, but seriously, we want this to become a more routine activity for the members of GAAPP to meet regionally. Thank you.
Yeah,
Great.
thank you.
Great job. All right. Next, we will go to the Middle East Asia Pacific group. Dr. Gupta.
We are the smallest group of all, and so our discussions didn't last long, and we were really focused, and Ghulam had good inputs to give me. The challenges that we identified was one, very, very rapid increase in the number of the patients suffering from allergy and atopy. And the statistics clearly revealed, because both of us have been working in the field of statistics also, and in the last 20 years, whereas the admission rates in most pediatric hospitals are up by 200 to 300%, but the proportion of patients suffering from asthma allergy is up by around 1100%. So there's a big gap. Disease prevalence is rising, and the proportion of patients suffering from respiratory disorders is the biggest increase seen in these areas. Now in the last 7-8 years, the food allergy has also started coming up. So from respiratory march, we are moving towards the food allergy march. The second important problem that we found was there was a complete lack of access to good diagnostic facility for allergic disorders, especially because the standard of care requires at least the skin prick test, which is not routinely available in most parts of Asia and Africa. Middle East, it is available, but not in Asia and Africa. So there is absence of any good diagnostic facility. So most diagnosis is primarily based out of clinical experience, and that is where the patient goes on for the treatment. Then the fourth was, there was a poor understanding amongst the patients about the nature of the disease. The patients that just do not know what the disease, the course of the disease is going to be, and so the compliance to treatment turned out to be inadequate, as well as inadequate information to the doctors also resulted in poor inadequacy of therapy. And the last point that we identified amongst the challenges was there was no national policy in most places, and in the absence of national policy, there was no integrated effort. So there has been effort with the medical community, some with the patient groups, but there has been no integrated effort. So what, again, the point was that we were to identify the biggest challenge. And when we thought of the biggest challenge, I think our point was the biggest challenge is to create an integrated effort between the government, the non-governmental organizations, and the patient groups. So if we are able to integrate all this, I think that's going to be the biggest challenge that probably is going to bring about a big change in the status. So our first answer to the biggest challenge is integrating the efforts of giving good patient care to all the patients suffering from respiratory disorders by integrating the government and the NGO and the patient groups. Now, the proposal to overcome this problem was, how do we strengthen the patient organizations? Because only when these patient organizations achieve a degree of respect, the way you've been able to deliver in GAAPP, where you have 50 publications and you are on the board and you are being invited as faculty, that is the kind of respect the patient organizations need to have, even in these countries, to have a position of creating an impact on the government as well as other organizations, especially the scientific bodies, to coordinate. And so in that area, we said we need to improve their communication. Number two, improve their activities and broaden their membership base. So the membership has to be spread all over. That's one example that we have picked from GAAPP, where you have spread the membership all across the world, and that's where I believe if the membership is spread all across the country, we'll have a much better strength to ask the government to respond. And we also need a global umbrella, because that is one region where if you have an umbrella, for example, somebody comes from the World Health Organization, the government accepts the words of that individual, oh, it's from the WHO. So we need, I think most of these associations will need the GAAPP umbrella to say that it is GAAPP Allergy Care India, so that that voice is better heard. And we also need to create a presence in the scientific meetings and publications. And patient groups also need to be incorporated in the policy-making body of the government and the scientific community. So that's the kind of intervention that is going to help these groups come to that level of influencing the policymakers. And finally, the issue was regional alliance. We have a large number of such scientific alliances from the medical fraternity in those areas. So regional alliances can be done, not a difficult thing. The only thing that we thought was that we have to work in a phased out manner, because we have 3 different regions: Asia, Middle East, and Africa. So it has to be done in a phased out manner, where we, in the initial phase, we bring in all those who are interested from all these 3 areas, and then proactively focus on Asia, then move to Middle East, and then finally to Africa. So that's the way we are planning to move in a phased out manner, with any individual who is proactively interested from Africa or Middle East or Asia is always welcome to join. But the focus is going to move from one region to the other to the other. Thank you.
Thank you, Ashok. Thank you, Ashok. Very good. I think Ruth has a couple of questions, so I'll leave this one with you, and I'll get the second handheld here. Thanks. And just if you'll introduce yourself and the organization, please.
Hi, Ruth Dalsinger from COPD Foundation. I have two questions. One of them, you mentioned increased prevalence. Is it because of increased prevalence or increased awareness? And it kind of ties to my second question, so I'll ask that too. Because as you talk about alliances, who would be the champion to bring patients and to organize patients together? Are clinicians likely to start bringing patient advocates and patient speakers into regional conferences?
So there are two questions. One is it a real increase or is it a perceived increase? Why I say it is a real increase, because the number of patients visiting, we are not based out of a community survey. It is based out of the patients coming to the hospital. The hospital, the number of people coming to the hospital has gone up by almost 200%. And the proportion of the patients with respiratory disorders has gone up by 1100%. So the gap between the visits to the proportion of respiratory patients is very high. The other way to look at it is from the industry perspective. The industry sales of all these asthma-related products is growing tremendously. It's one of our local companies, Cipla, is now become a global company because it has, I think, the biggest consumer base in India on respiratory disorders. So it's not something which is just perceived, it is a factual increase. There is another important thing that's happening from a scientific perspective is because of the environmental exposure to multiple things, there is methylation of the DNA that takes place, which is what most people would understand, epigenetics. So you are getting into a generation of gene expression of a different kind without getting into genetic mutation. And when DNA methylation takes place, the reversal doesn't happen in your lifetime. And that is why if you look at the people suffering from asthma, with severe asthma is on the rise in the Western world too. Mm-hmm. And that is, we are in the early stages of that change that is happening in that country. So all said and done, the world is going to see this epidemic. It's going to continue. It's a scientific logic. And unless we revert to our older pattern of lifestyle and older pattern of doing things, it's going to be bad. The second question was, how do you
bring patient advocates?
Okay, yeah.
Is there
I'll answer to that again. What happens is, in the rare disease group, we have almost around 35 patient groups which are very, very proactive. So because you have to have that sense that your child needs something which nobody else is going to provide, and then they become champions. And they have created, we have 32 patient organizations working in one specific area of rare diseases, which includes all kinds of rare disorders. And that is where it's not that it's always going to be driven by medical community. In the initial phases, yes, medical community, because we are a good link between the government and the society, because the government listens to us. And we are in the policy making, we are proactively able to influence the programs. But at the same time, it's a transition only. And we are all going to be replaced very soon because we are now getting very aggressive patient groups who are wanting to do things more. And because it requires a full-time effort. And for that, you have to have committed families and parents. So it's happening. There's a major change again.
Thank you.
Yeah, we'll go here.
Just to add to the point, I mean, it's bringing all the other organizations together in a network. Obviously, someone has to start. And those who are already working in it, obviously, they will bring the rest of the other organizations with them. They will inform them, as we usually do. We do call them, do talk to them, and many of them they start joining. Initially, maybe 30 to 40%, but over the time, 70 to 80% they join with us. So, I mean, we have to begin, and obviously those who are here, they would be taking the task to start it.
Taking it forward. Thank you so much. All right, we are going to go to our North America group next, led by Kristen Willard from the COPD Foundation.
Hi, everybody. My name is Kristen Willard, as she said. And I'm here from the COPD Foundation, and this fine group of people here represents North America. So we'll tell you a little bit about our challenges and how we propose to approach. So one of the biggest things that came up, these three sort of came up in one breath, right? But we'll start with insurance being a problem, particularly in North America. In the United States, it's a problem for our patients. They're not sure what is covered. Some things are never covered. Some of our patients in the COPD Foundation are going out of the country to online pharmacies in order to get their medications. So I'm sure I'm seeing some nodding heads. So I think we're not alone in experiencing that. One of the things that Diane mentioned, this is especially the case, that the insurance is difficult for biologics. She's here from urticaria, and we know that that's very successful in treating chronic urticaria, and some people will never have access to that. So that, of course, is a big issue for us. Access to care also came out in the same breath. This has many prongs to it, but a few things that we identified were rural populations being able to access care no matter where you live. And we heard that across many of these things you've already said, right? But we see that no matter where we live. One of the things that Ruth mentioned was in some cases in these rural populations that these individuals have no access to specialists, that they will never see a specialist. So that's something we need to take into consideration as a challenge. Another of our group members brought up the fact that there are long waiting lists for specialists in certain locations, if you even get to see one. And another thing I think we're all talking about in different ways are health disparities that exist no matter where we live. They may look different, but they are barriers to appropriate care, barriers to access, that we all need to be mindful of, I think, in the work that we do every day. And affordability, of course. I mean, this is the case even when you're in a position where you don't consider yourself to be disadvantaged in some way, right? That sometimes it's just prohibitive to even afford some things that you are prescribed. So I think, again, these were sort of the top three that came out. Then we got into a really deep discussion about awareness and education. So these are also themes I think we heard across groups. One of the things we really want to impress upon clinicians is the importance of early diagnosis, no matter what we are talking about here, right? No matter the condition. In addition, Ruth brought up care pathways, being aware of the care pathways and what those look like, right? And how you would use those in your care delivery as a healthcare professional. This is a huge one. Spending the time, if you have it, as a clinician to ensure that your patient understands what it is that you're saying to them, right? It's not easy. I think we all know that if we try to educate someone on something, sometimes it's just not an easy feat, but taking the time to do it, learning the best practices when it comes to patient education to ensure that you're able to communicate in the best possible way, and also reaching out to organizations like ours. That's a subtle plug, but it is for all of our organizations who have materials that we can share with clinicians, so that it makes that process easier. And then we've all been victims, I think, probably of inadequate follow-up, but this is especially important when you're dealing with a chronic condition, making sure that people have visits on the calendar and that they're adhering to those. Okay, let's move to patient education, equally as important. Getting the materials that we all have, getting those out into the hands of patients as well as their family members. We should not forget caregivers, given the influence that they have in a lot of the topics that we're talking about today. One of those being adherence, right? Imparting on people the understanding of what it can look like when you have optimal use of your medications for any of the chronic illnesses we're talking about today. Let's also pay attention to language, I think, and in general education barriers. In many cases, as we all know, no matter where we live, people do not have access to educational materials in their first languages, and I think that's something we're all looking to change. And also cultural barriers, understanding what people are willing to discuss, what they may not be willing to discuss when it comes to these conditions is important. Okay, a few more, and then I promise I'll pass it along. One of the things, and I can't remember who brought it up this morning, was this mindset that the condition has been sorted. I don't remember who said it, but that it's been addressed, that it doesn't need that attention anymore, and we can all say that that's not the case for our respective conditions. Oh, public policy being a low priority. That's something I know we're all looking to change as well. And the last thing I'll say is that it is interesting. We are all trying to get our messaging out, right? And trying to find strategic ways to communicate. But someone on our team mentioned that there is messaging overload at times, that you don't even know what to pay attention to anymore, right? So imagine for the people that are not as well informed in the patient community, or for that matter, in the clinician community. So let's talk about ways we might address, and my colleague will do that.
So ways to address patient advocate education from their prospective families together. I did want to mention one thing, because Dr. Gupta, I think, mentioned it a couple of times while he was speaking, as well as we were working in the rare disease group earlier, was about umbrella organizations helping each other. And this isn't really a question, it's more of a comment around, I've always really appreciated GAAPP being an umbrella organization that doesn't charge organizations membership. It drives me crazy. So thank you, GAAPP, for being that, Tanya, working with us, because there's a lot of organizations that are, and they charge smaller organizations that necessarily couldn't afford it. So going back to this is patient advocate education from their prospective families together. We're talking about the general population who we're focused on, policy and decision makers, whether that's whatever country you're in. I feel like Chris and I were talking about like how every table we've heard speak has the same kind of concept, and just depends on what country you're in, but it's the same for most. Having conversations with policy makers as well as industry partners as well as providers. These are all very, very important to be the patient advocate and be the patient voice, because if everybody's educated on these, it's going to help everyone in the long run, the patient, the provider, the industry, insurance, and then they can relay that to someone they know that might not be so educated around it. Going back to providers, this isn't just specialists, as some folks have already mentioned. This is going back to primary care and showing diverse populations. This was a big discussion. Allied healthcare professionals, since a lot of times the physicians are bogged down, and many times the allied healthcare professionals will see some of these patients as in physician assistants or nurse practitioners and those, because especially when you have a more urgent need that you need to get seen sooner, those will probably be the providers that, in the US anyway, that you would see. So that needs to be addressed too, with educating that population. Building partnerships with other organizations and industry to amplify the message. Again, it goes back, I feel like a squeaky wheel when it says, we need to connect with each other and how we can collaborate, because again, together we are a lot more stronger than if it was just one organization or just a couple. Educating professionals, reaching them for professional organizations and through social media. And would you?
This is around a strategy.
Oh yeah, around an initiative. And there was something else I was missing here. I think it rolled into yours. Oh yeah, the alliance. I think Diane was.
And you guys got 3 minutes to.
Dan's
all right.
Gonna do this.
Thanks. Not surprisingly, North America has the most challenges.
Hello. So we realized we could share some resources and use have a global strategy in our region to address those things. So like one thing we could do is amplify each other's messages. instead of fighting each other for like specific disease. Because there are unique comorbidities for each of our conditions. We could also create like shared resources that are applicable to all. Like, for example, like how to talk to your doctor, no matter your disease, that can be used by anyone. Like communication tools. Oh yeah, like the third point was we could create like a common forum so that we can like make our strategies together and like coordinate to create those materials and share them like around our like our organizations and like have common publicity, because we all know that that's a bit expensive, so we could share like that resources as well. So did I forget anything? No?
No, that's pretty good. Okay, yeah. Great job, North America. All right, if I can get my mic on. Again, being from North America, I'm not surprised that their list of challenges was a mile long, because we have 5,000 health plans in the U.S. rather than a single. So I worked with the Balkan group here, and I'll give a few updates and then ask my team members to weigh in as well if I miss anything.
Thank you.
So on the challenge side, really, we talked about, regardless, this is a very diverse group of Southeast Europe, but the challenges really are all within the public health systems and some of the access barriers. Their emergency medication lists do not include biologics, immune modulators, topical steroids in some cases, allergen immunotherapy, epinephrine, not covered on an EML. I can't believe that. I'm just astounded by this. Also in their public health systems, they don't have consistent access to diagnostic tools like spirometry and fractional exhale nitric oxide. They don't have coverage for environmental control products and things that could really help to reduce the exposure for our community. And then the access to specialty care, as we've already heard from other regions around the world, is less than optimal. And so there is no ability to really put the resources where you most need them with the uncontrolled and phenotype that group and figure out how to get them the treatments that they so desperately need, because that bottleneck of not getting to specialty care. There's also a lack of awareness just around patient rights and the ability to be that best advocate for yourself, and what does good care look like. There is misuse of medications because of the lack of access on the EML. It drives behavior to seek medications that may not be optimally used. There's also significant misinformation and challenges around language barriers. And as we heard here, just some of the cultural competencies and disparities that are created when you don't have that common language and a simple way to communicate it. And then there's no real quality standards and no national plans for lung health in any of these countries either. So some of the solutions that our group offered. Number one, we think it's very important that we have that patient healthcare provider industry collaboration, that no single entity of that triangle can do this alone. So it's going to take us all working together and collaborating to get the prioritization that is needed. We came to the solution really of a national plan, once again, for this area, like a sample template national plan that can be tailored to individual countries, but that is representative of the region as a whole, to get the emergency medication list expanded, but also to demonstrate some small wins, because it's with that momentum that we would actually see larger opportunities and get more significant support and funding. Workforce development, again, as has been said, there is very low recognition of GINA and GOLD guidelines, so that HCP education, but also the activation of public health educators and patient advocacy organizations working with public health educators throughout the region. This, by having a national plan and having that registry data, would allow us to have those measurable wins and to communicate that back to policymakers. The patient awareness campaigns, so we talked about an awareness campaign to drive awareness of patient rights, treatment options, and standards of care, as the three pillars of that need for greater patient awareness. And ultimately, some of what's already been said, but simplify, unify, translate really core key messages and not get so far into the weeds of every little best practice, but perhaps what are the 2 or 3 things in each of these areas that are going to make the biggest difference. And then using technology like mobile applications or text messages for education and awareness, and incentivizing people to engage with those tools on a more routine basis. Right. And then for our alliance or collaboration, we offered what has been said here before, that GAAPP as the umbrella organization have a regional alliance of Southeast Europe, and that it represents kind of these countries. And again, knowing that still these groups would be a part of the European group would certainly come to the table, but they felt that the need of this subset and sub-region of Europe are a bit more unique. And so that's why we suggested a Southeast Europe Regional Alliance. And then, like we said before, creating that sample national allergies and airways plan that would have 10 to 20 different strategies that could be tailored to each in-country need or health system. And then finally, we really talked about the need for the alliance and collaboration of patient advocacy and healthcare provider associations, which we've talked about here in other regions as well. But the best education and awareness always comes through those collaborations. And we have to find that common ground, the connection, and really build from that unique position. When we do get aligned on those, common ground points of every patient should have spirometry, every patient should have access to whatever medication. When we get that clear focused goal, it's amazing how quickly we can accelerate and move the ball. But otherwise, we sort of languish in the world of so many great possibilities. So I think that that's representative. Did I miss anything, guys? No, you were great. All right. Good job by everyone. I love how the common themes are emerging from these conversations. This is why I volunteer. I'll get a bit emotional. I'm trying not to do that. 4 hours a day to GAAPP. The reason I do that is because of this, because I come away from this so energized that we can change the world, not the US, which I'm super passionate about because that's my full-time job, but the world. Like if someone told you you could change the world for 300+ million people living with lung conditions. That's the power of this room and this activity. And so I'm super jazzed about this exercise and where it leads us. As I said, the board will go back. We will take this under serious consideration, come back to you with plans for each of these regions and for moving this work forward. So with that, we are 10 minutes from our keynote speech, which I am so excited for. I can hardly wait. But I feel like we all need a stretch break, coffee, restroom, all of that. Maybe some fresh air. This room is rather warm, I'm sorry. So we will take a 10-minute break. For those of you who are online, we will rejoin at 2:30 this local time here in Barcelona, and we will hear from our keynote speaker at that time. So enjoy the break. We'll see you back in 10 minutes. Welcome back, everyone. We are going to take a quick group photo before we have our keynote speech. So if you could come to the front of the room. Everyone come to the front of the room. No, it's Wi-Fi. We're going to have people seated in front to make sure. Oh, I'm so sorry. So sorry. So let's just move these forward slightly. All right. So I need all tall people on the back row. Those of us who are perhaps a bit more vertically challenged on the front or the middle, and then anyone can sit in the front. Ashok, come on board. Group photo. Group photo, group photo. We can share. Yeah, no, you're fine. That's good. No, no, no. Okay, everyone. Make sure that your face can be seen, because if you can't see him, he cannot see you. Okay? If you cannot clearly see him, he can't clearly see you. It's the rule of my household. We will share with everyone after. We'll send a group out to everybody. Okay? Wide lens. Got it? All right, great. Thank you all. Okay. Okay. Now, if everyone can take your seats, we're going to get started. That'll allow us to finish on time. Okay, everyone, let's get started.
Oh, no. This is for you. Thank you.
Guys, this is truly a treat this afternoon. So I have to tell you, when I was looking at how I wanted us to really celebrate being back together in person, I began to search. We're using these for the exercise, sorry. I began to search. Guys, if I could have your attention, please, sorry. So when I started planning the meeting and looking at, our time together, I began to search for the ideal speaker to help us really galvanize and then come together to recognize the level of influence that we can have as patient advocates. And as I began to do my research and look at different people throughout Europe, I came upon Duncan Stevens. So let me tell you a bit about Duncan. Duncan Stevens is the founder of the Influence Association and the author of a best-selling book, Effective Influence. He runs a number of successful businesses and delivers influence and persuasion presentations all around the world. His effectiveness influence model unlocks the real secret to creating long-term influence and client relationships and has helped some of the world's most recognizable brands and companies. Today, he's going to share some of those secrets with us. So welcome, Duncan Stevens.
Thank you so much. Would you be all right to shuffle back that way a little bit for us? Perfect. Good. Let you get comfy as well. Perfect. So, good afternoon, everybody.
Afternoon.
Come on, you can do better than that. Good afternoon, everybody.
Good afternoon.
Perfect stuff. So, thank you so much for inviting me. I'm very excited to be here. And as you've heard, my name is Duncan Stevens, and I want to start by introducing myself. I'm three things. I'm a keynote speaker, so I travel the world helping brands, companies, teams, and leaders become more influential, more persuasive, and more collaborative. I'm number two, the founder of the Influence Association, and author of a best-selling book. And number three, perhaps the most intriguingly, I'm a mentalist. Does anybody here know what a mentalist is? Not a crazy person who's
Yes.
doing that? What's a mentalist? What do you think it is?
Someone who is able to get what the person wants with some kind of
Maybe.
NLP or
Yeah, a little bit of that. So a mentalist is somebody who uses suggestion, psychology to influence and persuade people under the umbrella of entertainment. Okay, you know, yes? So hopefully we're going to have a little bit of fun with that a little bit later on today as well. So why is all of this important? Well, it doesn't matter if you've got a great product or in your case a great service. If you can't get people to buy it or even believe in it, then it doesn't matter how great it is as well. And as Tony said, you can really change the world with what you're doing. But even more so than that, change your words and you can change your world. So, we've only got a short length of time together. I think we said, what, 4.5 hours was it?
Yeah,
I'm joking.
yeah,
We've only
something
got
like
a short
that,
length of time. And in that time, I want to give you some tips, strategies, tools and techniques to help you become more influential, more persuasive and more collaborative, and hopefully have a little bit of fun along the way as well. Does that sound good?
Yep, sounds great.
Perfect. So, before we start, I want to introduce you to somebody. Does anybody recognize, if we can get this
Over there.
working? Anybody recognize this? It's over there, is it? No? This is Sir Tim Berners-Lee. Sir Tim Berners-Lee, he invented the World Wide Web. And when he invented or founded the World Wide Web, he faced two challenges. The first challenge he faced, he had to influence his employer's CERN and collaborate with his partners to bring the World Wide Web to reality. The second challenge he faced, and perhaps the even greater challenge, he had to influence his employer's CERN and collaborate with his partners to make the World Wide Web absolutely free. Now, would we all agree, had it not been his ability to influence and collaborate, the world would be a completely different place to what it is today. Thus, our ability to influence and persuade and collaborate is often even greater than the idea itself. So, with that in mind, I want to start by sharing some of my skills. Because if we're going to approach this presentation through different eyes, we want to be thinking about doing things a little bit differently. And to do things differently, we need to do different things, because if we keep doing what we've always done, we'll always get what we've always got. So we're going to try something a little bit different now. A little piece from my mentalism and something with your collaboration. So if you could choose 2 men, 2 women to come up and help me out with this. When they do come up, we're going to make them feel very welcome, give them a round of applause, and they're going to stand in one long line up here. Who do you want to choose? 2 men, 2 women?
2
Fire
men,
away.
2 women.
And I'll give this for you for now. Keep hold of that, don't open it up.
Yes. Yes.
You can
2
come up as a
men.
woman then
You're
if you want
men.
to. That's the one woman. Up you come. Let's give him a round of applause as he comes up.
Yes.
Come and stand over here. Armando. Amazing.
2 men.
Armando.
2 women.
Perfect.
Would
If
you
you
come?
hook that over yourself with
Oh,
the name
no,
tag
no
out.
English? Okay. No. Yeah, you do speak English. Get out there. Yes, you do. You said
Iransu,
whatever I need.
Iransu, I'm not going to make you
You
feel silly.
said whatever I
What's your name,
need.
sir?
Look, you
Dave,
earlier said whatever you need. Yeah, see, get up.
Perfect,
Okay.
thanks so much. If you could stand up
You
here.
shouldn't have said that if you didn't mean it.
Thank you. Don't worry, I'm not going to make you feel silly. What's your name,
Okay.
sorry?
And Ilya.
Yeah. Complicated. Very complicated. Can you come and stand on the end there for us? And the last person, what's your name, sorry?
Lilia.
L.
L-I.
E.
No.
I. L. I.
M.
L.
I.
I.
A.
Ah, perfect. Have yourself and stand on the end there. Stand on the end there for me. And if you come and stand in second place as you were second up, Armando, come and stand up here. Perfect. So, first up was Armando. Armando, you freely get to sit in any one of these 4 chairs. This chair is the most comfortable, but don't feel like I'm influencing you to sit on that. Off you go. Any one of the 4 chairs. There we go. So one of the most predictable things about people is the fact they believe they're unpredictable, and by default makes them more predictable. Now, he knows that I know by suggesting this chair, he's going to not sit on that. But he toyed with me a bit. But leave your name tag out for me. Dave, you're going to sit on any one of the other 3? Perfect. Iransu, any one of the other 2? Perfect. And Lilia, the final choice, the final chair, should we say. So I'm going to give each of you an envelope. Keep it face down, don't open it up. Face down, don't open it up. Face down, don't open it up. So this is going to represent collaboration and influence. So, Ilya, you're going to swap envelopes with Dave. No. You're going to swap envelopes. Swap envelopes with Dave. Perfect stuff. Change, sorry. You're going to change them again. Perfect. In itself, it does nothing, but what it does, it conditions them to this next routine. So Dave and Lily, you're going to swap or change envelopes as many times as you want. You've got 5 seconds. Off you go. 5, 4, 3, 2, 1. Stop swapping. Perfect. So Armando, you were first up. You're going to swap places with Lilia. Do you want to keep your envelope or do you want to change your envelope? You want to keep it? Okay, perfect. Swap places and keep your envelope. Swap places and keep your envelope. Perfect. Dave, you were second up. You're going to swap places with Iransu. Do you want to keep your envelope or swap your envelope? Okay, swap envelopes and swap places. Perfect stuff. These are their free and fair choices. If you keep that under there for now, perfect. Yeah, perfect. Lilia, I'm going to give you the chance again. Do you want to swap places with Armando?
Yes.
Okay. And you want to swap your envelope as well? Yes. Yeah, okay. Fair enough. Bear in mind, these are their choices. Armando had the first choice. He had the second choice. Dave, do you want to keep your envelope?
Yes.
Iransu, do you want to keep your envelope? Who do you want to swap it with?
With Armando.
Okay. Swap your envelope with Armando? It's up to you. You can swap if you want. You weren't happy about the change. Did you want to change back? Yeah. Okay, change back. Or did you want to keep your envelope at the same time? Okay, give her your envelope and then swap places if that's what you want to do. Perfect. But I want to emphasize the fact that these are all their free and fair choices. Would we agree they're completely fair? Yes? Yeah. Yes. Don't open up your envelopes just yet. Don't open them up. Inside of here we have a slip of paper for you. If you keep your name tag out as well. Keep it closed. Keep it closed. Inside of here we have a slip of paper for you as well. Dave, if you open that up for me. Yeah, go ahead to open that up. We should have a slip of paper in there for you as well. And finally, we should, yeah, all open them up. Open them up. Open them up. And then if you hold them above your head, hold them up above your head. We've got a 4 there. We've got, okay, so not necessarily, yeah, open it up. Open. There we go. Yeah, perfect. And hold it up. Perfect. So not necessarily 1, 2, 3, 4, but they all had their choices. I did give out an envelope beforehand, our mission, let's say. If you open that up, and they had a free choice to collaborate. If you hold it up and read it out loud as well. Read it out loud. I'll read it out loud then. 4, 2, 1, 3. Let's give them a 4 big clap. But. It is just 4 numbers. It is just 4 numbers. And if you take any 4 numbers and arrange them in any particular order, it doesn't really mean a great deal. It's only 1 in 250,000. But, at the back, we'll discuss the how at the end. But, if we add in another 4 numbers, they decided to whether to stick or switch. But Armando, at the last moment, decided he wanted to stick back in his original seat. If you open that up, hold it up so everyone else can see. Hold on to it. Dave, if you do the same. Iransu, you do the same and hold it up. Let's give him a big clap as well.
No.
But, again, it is their choice. They had the choices, and you saw how free and fair their choices were. If all 4 of you reach under your chairs, there should be a slip of paper. If you take that slip of paper out and then hold it up so everyone else can see, we should check it out. Go mad for it. Let's give him a massive round of applause over here for Duncan. Amazing stuff. There's no more numbers. Can I have your name tags back? Let's give our 4 participants a big clap as they sit themselves down. Thank you so much. Thank you so much. Thank you so much. Perfect. Good stuff. So, whilst this was a nice little experiment for you guys, I think it's also important that you should also experience, everyone in this room should experience your abilities to influence one another. So, on your tables, you've got some ribbon. What I want everybody to do in get into pairs of 2, so 2 of you, take the piece of ribbon and lay it down in front of you and then face one another. So everybody stand up, everybody put your phones down and stand up. And then one piece of ribbon between 2 of you.
Okay.
So one
ribbon,
piece of
two
ribbon,
people.
2 people. So if you, one piece of ribbon, and then you two face one another, and maybe if you want to choose somebody else, if anybody's spare, and lay it on the floor, lay it on the floor.
Lay it on the floor.
So make some space, and you're going to face one another with the line in between you.
Okay.
Amazing. In between you. So it's the other way, horizontal, like that.
On the floor.
So you're facing one another, and the line is, so the line is like this, face down. You're facing outwards, and the other person is facing this way. So it's not like that. Okay? That's right. Perfect. Are we good?
Yes.
Are we good? Have you got a friend? Yes?
Do you have a friend?
Perfect. Good. So this is the game, should I say. You have got 2 minutes to influence the other person to step over to your side. Did we catch that as well at the end? Did we catch that? Did we catch that? Yes? 2 minutes to influence the other person to step over to the other side. Once the blue line reaches the end, that's time up.
For you to talk me into coming over there.
So you're going to face one another. Face one another. You're not... Okay, that's good. If you do.
Would you like to come over to my side? Would you like to come over to my side?
I don't know. What did you do? Okay. 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 And that's what you think is the solution.
There we go.
Okay.
Okay.
Maybe think more. How could that be better? How could it be better? Have a think. Have a think. Could it be better? Could it be better than that? Did you influence him? She influenced you? Yeah. Okay.
We influenced one another to meet in the middle. And she immediately did. We were very compliant, loving.
Have you done it?
Yeah.
I think maybe the only people have done it right. Everyone else maybe has done this.
We're in the middle.
Maybe not then. Okay, guys, everybody grab a sit down.
Okay.
Everybody grab a sit down. Pick your ribbon up. Put your ribbon on the table. We'll come to that at the end, don't worry. Maybe. We'll try something else.
It's so warm in this
So, hands up if you're able to do that. Hands up if you weren't able to do that. Hands up if you won't put your hand up no matter what I ask. So, thank you. So I saw a bit of blackmailing going on at the back. There was a bit of incentivization. Some people were pulling. Other people just simply stepped over, which is one way of doing it. But looking around the room, for me, nobody did it 100%. I'll explain at the end. And I'll explain through the course of the content where I'm going to share some influence tips, tools, strategies with you. And hopefully at the end, we're going to repeat this. And you're going to take one of these influence strategies and apply it again. And hopefully, you'll be able to take it to that extra step and really amplify your influencing abilities. So before we start, when I started looking into influence and persuasion and creating my effective influence model, I wanted to draw from the best of the best. So we'll start with this gentleman. Does anybody here know who this is? Not my dad, no. This is Joe Girard, an American Chevrolet car salesman who, in 1973, sold 1,425 cars. Now, I'm not talking to a room of car manufacturers or car salespeople, but what I'm about to share is directly applicable to any organization if you take it more than just what it is for face value. Over the course of his life, he sold 13,000 cars. Because of this, he got featured in the Guinness Book of Records. So I looked into what were the secrets to his success. He attributed 3 secrets. The first, he sold more than just the car. If anybody came back in to have their car serviced, he would prioritize them above everybody else. He would get 3 or 4 mechanics working on them and sometimes even pay for the parts themselves. In return, they would come back. He would ask them to come back. Secondly, he treated his customers and his team like a family. Now, I can sense the family here, but he also did this for his customers as well. Once a month, every month, he got an artist to hand commission a card, and inside he simply wrote, "I like you." This activated a very powerful principle of persuasion, of reciprocity. And what about his team? Once a month, every month, he took his team out for dinner, and in return, they worked harder, longer hours, and delivered higher levels of customer service. And a final thing, he was just an ordinary guy, which made him a lot more relatable and likable. And people want to work for and alongside those who are likable and relatable. In 2017, his record was eclipsed by another American car salesman, Ali Raider, and his secrets are no different. It's not about me. One of the fundamental keys to fundamental keys to likability is putting the other person first and being as interested in them as they are about you. But I thought to myself, surely this can't be as simple as that if you're trying to influence patients and caregivers or influence advocacies. So one of my colleagues, he identified 6 and potentially now 7 different principles of persuasion where you can take from these as you will. We don't have time to go into them all today, but it's some of these you can apply at the end as well to increase your influence levels even further. Consensus or social proof. People say yes to recommendations that have been made by the majority of people around us and are amplified by those who are like us. Authority. People say yes to people in positions of authority. Like the police, like teachers, like our parents. Reciprocity. People say yes to people that they owe. If you give first, people are more likely to give back, often to a higher perceived value. Scarcity. People say yes to goods, products, services that are rare, scarce, or dwindling in availability. Consistency. People say yes to requests that align with commitments they've either said or done publicly. And finally, likability, like Ali Raider and Joe Girard. People say yes to people who are likable. They want to work for and alongside people who are relatable. So I took all of this and some other ideas and created my effective influence model. Now, these words are nothing new to anybody, but it's the detail inside of the detail and they're working together which makes this so important. And we start with collaboration. But before we start, I want to ask a question. Are you a manager? Are you managing something? It could be managing patients, managing a team. Hands up if you're a manager or doing any form of management in your organization. So I would say that's about 95% of you. Let me ask the same question to the same people. Are you a leader? Yeah? Now, I know it might sound a little bit twee, but the language we use in any given context is directly relatable to how we think, feel, and act and behave. And equally so, how others think, feel, and act and behave. The very definition of managing is to cope. You don't get up in the morning and say, oh, what are you going to do today? Oh, I'm just going to cope. I'm just going to firefight. No, you're going to lead. You're going to lead the patients, the caregivers, the policy changes. You're going to lead them to the next step in the process, whether it's selling something, buying something, whatever it is. So the very definition of to be a great leader is to create self-managing teams. So you can do this overarching, broader focus. So let's look at some of the best leaders I've come across, or some great leaders. By a round of applause, who would say this is a great leader? Yes? Great leader? Yes? How about this? Who thinks this is a great leader? Yes? How about this gentleman? Is he a great leader? Let me have a look. If we can turn the slide. Are we going the slides? Are we going about this man? No, exactly that. This is more collusion than collaboration. This is Boris Johnson from my country, unfortunately, embarrassingly so.
Embarrassing.
How about this man? Round of applause if you think he's a great leader. Yes? How about this lady? Amazing. And finally, any others you'd like to contribute as great leaders? Could be from your country. Gandhi, absolutely, comes up a lot.
Yeah, definitely.
Second. Somebody here? Do you have something? No? I want to share with you a leader who I think really sets the tone for great leadership and great collaboration. And this is somebody that many people overlook. In fact, most people overlook. Does anybody know who this is?
Dorothy. Wizard of Oz.
Exactly. Judy Garland, Dorothy from The Wizard of Oz. Now, we all know the story of Dorothy from The Wizard of Oz. She had to get to the Emerald City to ask the Wizard of Oz for help to get her back to her hometown of Kansas City. And did she do it alone? No, she did it with the help or collaboration, as Tonya mentioned about 3 or 4 times in the solutions to your challenges, collaboration with 3 other characters: the Tin Man, the Scarecrow, and the Lion. Had it not been for these 3 other characters, she would have fallen asleep in a field of poppies and the Wicked Witch would have stolen her shoes. Had it not been for the 3 other characters, she would have remained captured in the castle and not managed to escape. But equally so, she managed to help them achieve their goals. The Tin Man, of course, found his brain, the Scarecrow a heart, and the Lion found courage. But equally inside of that, there was a dynamic to help them as well. She oiled the Tin Man to help him move. She stuffed the stuffing back in the Scarecrow, and she wiped the tears from the Lion's eyes. But equally inside of that, the collaboration was within them as well, where the Tin Man, he put out a fire to stop the Scarecrow catching light. Now, you might be thinking, well, that's all great. It's a nice story to tell. It's a different perspective on things. But how can we use this in our organisation, in your organisation? Well, I want to give you a framework with 3 important features or structures to enable you to ask better questions. Because better questions lead to better relationships. Better relationships lead to better sales and helping move the business forward and helping understand the needs of your clients. So let's take a triangle to make this happen. The first thing we need to think of is we draw inspiration from the Tin Man and his brain, and that is curiosity. Once we have curiosity, we dance our way over to empathy, a massive and fundamental part of the organisation. And finally, we take inspiration from the Lion, and that is of courage. Once it's all complete, this is a better photo, so don't be too preemptive. So if you turn up to any conversation with curiosity, you're looking to aim for one goal, and that is to create certainty. Equally so, have you ever had it when somebody turns up to a conversation so certain about something, you're curious as to why they're like that? So if we turn up with curiosity, we're able to create certainty. And this triggers a very important switch in their mind, which is this: show me that you get it. Once you show them that you get it, you can dance your way over to empathy. The best definition I ever heard of empathy is caring about what the people you care about. I think it's a beautiful thing to say and a lovely thing to let sit for a second. Empathy is caring about what the people you care about. And if you do that, it reaches the goal of relatability. And if you reach the goal of relatability, it triggers a switch in their mind, which is show me that you know me. So if you show them you get it and show them that you know them, this builds trust, one of the building blocks for any successful relationship. Leads us to this last piece, the courage piece. Courage, most people don't have the courage to do one thing, and that is take action. Courage to ask one more question. Finish this for me. If you do not ask, you do not
get.
Exactly. So if you're trying to influence your policymakers, maybe asking that question is that fundamental or key point. So how do we tie all of this in together? This puts you in a position of a trusted advisor or somebody to make a recommendation. Because you've shown them that you get it, shown them that you know me, you can now make a recommendation with the following very powerful phrase: because of the fact that you said. Because of the fact that you said X, I would recommend this. But we don't have to influence people by ourselves. We can also draw on the thoughts and suggestions of other people by triggering consensus or social proof, which is this: instead of trying to influence others by yourself, it can be wholly more effective to point to what other people are already doing or already have said or done. Let me give you an example. If you've got product A or service A, service B, let's use Facebook as an example. Product A has got 100 likes or 100 recommendations, and product B has got 20 likes or recommendations. Which product are you more likely to buy?
A.
Product A, right? But if I was to say that product B or service B, of those 20 likes, they're people that you know, people that you trust. Which of these are people more likely to buy now? Product B, right? So this was looked into a little bit further, consensus or social proof, by a group of psychologists who went into a hotel. They were invited into a hotel to see if they could increase the amount of towel reusage. Now, you've been into a hotel where you've seen these little pile of towels and a little sign on the top. It says, help reuse your towels. You've seen some of these, yes? So they had 4 signs made up to start off with. First one said, help the hotel save energy. Second, help save the planet. Partner with us to help save the planet. And finally, help save resources for future generations. With these 4 signs, what percentage of towel reusage went up? Do you think it went up by?
Went up.
They went up, yeah. What percent? Pardon? Pardon? What percentage? I'll tell you. No, it's 16%. It's nothing major. There was no social proof involved. So this is where the psychologists got involved. It gave them the opportunity now to create another sign to inject a little bit of social proof. They created this sign. Please join your fellow guests in helping save the planet. 75% of guests participate in our resource savings program by using their towel more than once. What percentage do you think towel reusage went up this time by? Yeah, not quite as high as that. But yeah, 44%. Simply by changing the language. But they thought they could go one better. They made a 6th sign. It was this. Please join your fellow guests in helping save the planet. 75% of guests staying in this room use their towels more than once. What percentage do you think this went up to now? Still not a bit high. 49%. It's still a big number. Was there any opportunity cost? Was there any cost? No, no cost involved. Simply by changing their language and pointing to what other people are already said or already doing. And this is a really powerful way how you can influence patients, caregivers, and advocacy leaders, or become advocacy leaders. But you can also use this in your organization, and what I've seen here is pretty much what this is, stacking. Stacking, you can leverage you guys to a very powerful transformational change. Stacking is the whole is greater than the sum of its parts. Yep. So what I ask people in their teams to do is use stacking to a collective advantage by using you guys for your own thoughts, suggestions, or ideas. The only rule of stacking is nothing is too insignificant. As soon as somebody says something or suggests something, share it, because off the back of that one idea, thought, or suggestion, somebody else may come up with another thought, suggestion, or idea, and very soon everybody is involved in the collaborative process and creative journey. It's the sum of all these ideas together which is greater than that one idea at the beginning. So much like following on from your thoughts and suggestions on the wall today, if they're really put into place, this is where you'll make the biggest movement. Let me emphasize it a bit more with just this little picture here. Does anybody know where this is? Yeah. Yes? Oh, you were the first one up to say that, were you? Wink and a point, of course you did.
He's a newlywed.
Oh, is he? Oh, right, okay. Where is it?
It's like a
Absolutely.
sexy clothing for...
Clothing, lingerie shop. Exactly, yeah. So La Sanza is a lingerie shop. So if you go into a lingerie shop like you frequent, is you usually get this, you usually get buy a little piece of fabric, but you don't get given it in a little carrier bag, no. You get it in a paper bag with a cardboard base. It's got rope handles. It's got little tissue paper. It's got aromatic beads. It's got some extra business cards in there. It's got a gold sticker on the top. It's the sum of all of that, which is greater than that little piece of fabric that you got in the first place. So think about that, all the packaging around it. Which leads us to the second part of my effective influence model, authenticity. And I want to start by a little story. Are you good for a quick story?
Sure.
Yes? So I heard this from a guru in India when I was traveling out there. And this was a story. One day there was a bull. There was a bull grazing in a field. And on the back of the bull, there was a pheasant picking ticks off of his back. The pheasant looked up at a tree and he said, oh, one day, many years ago, I used to have the strength to get to the top of that tree. Now I don't even have enough strength in my wings to get to the very first branch. The bull looks back at him and he said, let me help you with that. The pheasant was very curious.
Honestly, I can help you with it. Eat a little bit of my dung every day, and within 2 weeks you'll be able to get to the top of the tree. The pheasant wasn't so sure. Honestly, said the bull, the whole of humanity is onto it. So the pheasant started pecking at the bull's dung. And sure enough, on the first day, he reached the first branch. Within a week, he'd reached the top of the tree. As he sat there overlooking the field as the sun was going down, there was a fat old farmer on his veranda. He spied the pheasant at the top of the tree, took out his gun, pulled aim, and shot him right off. The moral of the story: bullshit will get you to the top of the tree, but it won't let you stay there. So whilst it's a funny story, I think it serves as a good example to a question I get asked a lot. So how can you use influence and persuasion strategies yet still remain authentic? And the answer is simple. Highlight the value that's already in your service, already in your product. Let me give you an example. Somebody got a pen? Somebody got a pen? Yes? Their own pen? We can use this pen. It's okay. What's your name? Ursula, perfect. So we've got Ursula's pen. Ursula's pen. If I take Ursula's pen and I chuck it on a table at a yard sale or a car boot sale, how much is Ursula's pen? Pardon? €0.50, yeah. $1, $2, 50 cents, yeah. What about if I take Ursula's pen and rather than chuck it on a table this time, I put it in an acrylic stand upright, acrylic stand alongside 12 other pens. On front of the acrylic stand, there's the manufacturer's name. Behind that, there's 12 different colour palettes. It's not just chucked on a table at a yard sale. This time it's in a department store. A mid-priced department store in America. Store in question this time is Macy's. How much is the pen? $5, $10, $20. It's the same pen. It's the same pen. What if I take your pen and this time, rather than have it vertically, I lay it horizontally. I lay it horizontally and put it in a mahogany box. Mahogany box is velvet lined. So we've got Ursula's pen in a mahogany box which is velvet lined. And it's not on a counter this time. It's in a glass cabinet. The glass cabinet is spot lit. So we've got your pen in a mahogany box, velvet lined, in glass cabinet spot lit. It's not in a Macy's this time. This time it's in London, in Knightsbridge. The store in question this time is Harrods. So we've got your pen in a mahogany box which is velvet lined, in glass cabinet is spot lit. It's in a store called Harrods. And to get to the pen, you need to speak to a member of staff. A member of staff is wearing a black tuxedo, he's got white gloves on, and his name is Pierre. How much is the pen?
Probably
100,000, 4,000. It's the same pen. I can't think of a better way to explain the importance of value. There's people, thank you for that. There's people all over the world paying demonstrably different prices for essentially the same thing. What's the difference? It's all the packaging and the pricing that surrounds it. So the clearer you can get about the differences opposed to the similarities, the easier life will become. So I don't know how important price is for you guys, but hands up who's paid more for something than they ever wished they had or ever thought they were going to. We all have, right? We all have. Why? Because people don't have budgets, they only have desirable outcomes. So if we put price here and value out here, which one looks bigger? Value? Price. Price. Are you short-sighted? What about if I swap it here and put value here and price out here? Which one looks bigger to everybody? The value. Yeah? So focus on the value and life becomes a little bit easier. So how can you incorporate value into your organization? So again, we take a principle of persuasion of authority. So a group of psychologists were invited into a real estate agents to help increase the number of contracts signed and number of appointments booked. So they looked at the first point of contact that people were calling in from. And the way that they were calling in and then the calls were being transferred in a very generic way. Oh, you want to let your house? Let me put you through to Sandra. She's in charge of lettings. Somebody wants to sell their house. Let me put you through to Tom. He's in charge of selling houses. They saw this as a real opportunity to add the authority and value into the call. So rather than this generic call, Somebody called up, wanted to let their house. They found out a little bit of information. They said, oh, Sandra, you want to speak to our head of lettings. She's got over 15 years experience. She's just let a house in your neighborhood, and she's a specialist in houses in your neighborhood. Someone calls up to sell their house. Let me put you through to Tom. He's the head of sales. 15, 20 years experience. He's just sold a house on your street for $1.5 million. How do people feel then? Wow, I'm being looked after personally. Not only am I being looked after personally, that person's had all of their credentials inflated by a third person, so they're not being boastful. What happened? Appointments went up by 20% and contracts signed went up by 15%, simply by changing the language and inserting some value and authority. Which leads us to this. Does anybody recognize this man? This is a guy called Stanley Milgram, listening to one of my keynotes. This is Stanley Milgram, a psychologist, and in front of him is an electroshock generator. This is one of the most controversial and now banned social experiments ever conducted. So, a group of participants were invited in. One of the participants, actually an actor, would be in an adjacent room, supposedly connected to the electroshock generator. The genuine participant would be sat in front of this electroshock generator, and our participant could not be seen, but they could be heard. If this participant administered a shock, they would hear the other participant yelling out in pain, "Ah!" They had to learn a series of pair words. If they got any wrong, our genuine participant would have to electrocute them with a shock. Our position of authority was made by Milgram, white lab coat. That was his position of authority. If at any point our genuine participant got nervous about administering a shock, Milgram would say, "You must continue. It's important you continue. Please continue. The experiment depends on you." With all of this in mind, and to put it in perspective, if you were to take an elastic band and pull it back, whack your back of your wrist, that's 15 volts. What percentage of people went all the way up to a lethal 450 volts simply because a man in a white lab coat told them to? What percentage do you think? This was where the participant was no longer shouting out in pain. They were quiet now. What percentage? Pardon? Not all of them. 60%. 60% lethal 450 volts. What percentage of people went up to 350 volts? I'm from England. If UK power supply is 240 volts, what percentage went up to 350 volts? This was now 100%. 100% of people electrocuted somebody else simply because a man in a white lab coat in a position of authority told them to do so. Now, I'm not suggesting you electrocute in order to influence and persuade, but I am asking you to take the idea of authority and how powerful it actually is. Let me show you a little clip of that, just to give it a bit of context. Hopefully we'll get some sound as well.
Cloud. Horse, rock, house. Answer. Wrong. 150 volts. Answer, horse.
Experiment, that's all. Get me out of here. Get me out of here, please.
Continue, please. Go right on.
I refuse to go on. Let me out.
Refuses to go on. The experiment requires you continue, teacher. Please continue.
Participants didn't know that the learner was really an actor, and the so-called shocks harmless.
You're gonna get a shock. 180 volts.
I can't stand the pain. Let me out of here.
Can't stand it. I'm not gonna kill that man today. I mean, who's gonna take the responsibility if anything happens to that gentleman? I'm responsible for anything that happens here.
They're not getting paid, no. Not getting paid, whoever said that. Which leads us to this, the final part of the effective influence model of communication. Again, these words aren't new to anybody, but it's the detail inside of the detail, like I said, makes this work. So, let's start off with a little experiment. Everybody pop their phones down, and everybody make a circle with your hands. Everyone make a circle with your hands. Everyone make a circle with your hands. And as quickly as you can, if you'll touch your chin, quick as you can, touch your chin. This is your chin, guys. This is your chin. Oh dear, too much alcohol, I think. So whilst this is, you can put your hands down. You can put your hands down. So whilst this is a fun little experiment, this is the chin. This is the chin. This is the chin. So whilst it's a fun little experiment, sometimes we think of ourselves as great listeners, but we're not always great listeners. A good listener sees himself as somebody who listens, waits for a gap in the conversation to reply. A great listener waits for a gap in the conversation to ask more questions, to understand. So the difference between a good listener and a great listener simply comes down to intent. If we change our intention, we can understand their needs, understand their wants, and serve them better. Now you might think, oh, it's just easy enough to ask somebody what they need, but at best they'll only tell you what they want. If Henry Ford asked people what they needed, they would have said faster horses. So we need to change our questions again. If we ask better questions, we can understand their behaviors. If we understand their behaviors, we can understand their needs and we can serve them better. It comes back to this empathy piece. Like I said, caring about what the people you care about care about. So if somebody's hungry, battered, bruised from the pandemic, you don't start trying to sell them cookery courses. Instead, you give them a meal, you give them a drink, you put your arm around them, you make them feel comfortable, and only then starting to talk to them about what's next. So, before we move on to a principle of persuasion to support all of this, I want to ask you guys a question, which I'll change from the biggest sale you've ever completed, but what's the biggest piece of influence you've ever done? Anyone to share? I'll give you a little clue. This. Hands up who's married, been married, or about to get married. Yes? Yes? Good majority of you. So yes, I see it. So I'm looking around the room, I see ladies and guys who are handsome, smart, intelligent, funny, money, wealthy, drive a nice car, all the attributes. Who wouldn't want to get married to you? But you might have a great product, great service in your case. Who wouldn't want to use it? It's got all the bells, all the whistles. So let's choose somebody who's with all the attributes, somebody smart, funny, handsome, intelligent. Gentleman at the back, if you'd mind standing up and choosing somebody smart, intelligent. I'm joking, we'll use you. You've got to sit down. We'll choose you, You sit down, it's fine. How long have you been married for? 39 years, wow, 39 years. So 39 years. So now your wife knows you as amazing, funny, handsome, intelligent, all of these attributes that she's probably not. You're being modest, and modest as well. All of these attributes. Do you think with her now knowing all of these attributes, if you'd asked her in the first day or first week to marry you, would she have married you? You might say yes, because the confidence is, you say yes. Maybe not, right? For the majority of maybe not. Why? They might have thought you a bit weird and run a mile. The same as if you're trying to sell your product or service. If you try and sell it too soon, too quickly, people will think you're needy. Worse still, pushy, or both. So the first part of this analogy to marriage is pace. It comes back to this conversational piece. We need to slow the pace down a little bit in any conversation to understand their needs, get some clarity on their specific situation, and explore their specific situation further. Because when we slow the pace down a little bit, it also allows us to do one other thing, and that's increase the level of trust. Does your wife trust you more now than she did 30 odd years ago? Yes, should be the definite answer. Yeah? Why is that? Because trust first has to be earned and then builds over time. So the same for this. If we slow our pace down a little bit to understand their specific needs and context, it allows us to increase that level of trust. But there's another important factor here, which is sometimes overlooked, and that is consensus. On a scale of 1 to 10, we're choosing you all the time, but on a scale of 1 to 10, how nervous did you feel when you were introduced to your wife's parents, now wife's parents for the first time, friends and family? 10, right? 10, 9 or 10. Why? Because you know the influential power that they have or hold over influencing her. And it's the same as if you're trying to influence other people within your organization or outside to make changes for the better in the world. We need to think about consensus. So often we think about speaking to one stakeholder or one part of the organization and selling the value of our product or service into them, working our way down the list of different stakeholders, achieving a series of yeses. Far better would to understand the overall common challenges and goals and sell our value into them through the understanding of the whole organizational goals. But it's not just to sell our product or service, it's this piece, the change piece. So your wife probably already had a Dream Boy picture on her wall before she met you. Or your picture, modest and confident both together. So she also had to think about changing from being single to being married as well. And the same with here. We need to think about change. First of all, rather than just going straight in and selling our products or service, we need to think about gaining consensus for them to change. We're creatures of habit. We love the status quo. People are happy in the situation they are right now. So we need to highlight to them why a change is necessary and what we can provide to them and the value we can provide to them as well. Which leads to this. Bit of a jump. This is Mexico in 1985. Mexico in 1985 suffered a massive earthquake. And in that same year, Ethiopia came to their aid with $5,000 worth of aid. Now for a country, well, for you guys it doesn't sound like a massive amount of money, but for a country like Ethiopia, that's a massive amount of money. Why? Because Ethiopia was ravaged by sickness, famine, poverty. And why did they do that? Why did they donate $5,000 worth of aid? Because 50 years before that, Mexico had come to their aid when Italy invaded them in 1935. This is that powerful principle of reciprocity. Even a country feels that it needs to pay back a country that it already owes. I want to give you a psychological background to it as well. A group of psychologists were invited into a restaurant to see if they could increase the number of tips given. So there was 3 groups of waiters. The first group approached a table after they'd finished eating with a bill and a sweet. 1 sweet was given. What percentage increase above standard tips do you think it was? It wasn't very high. Any guesses? Would you say 2? 2? Yeah, close. I don't know if you said 2, but it was 3%. 3%. Just above, just simply by the bill and 1 sweet. Second group of waiters, rather than 1 sweet, this time they gave the bill, and this time 2 sweets. What percentage increase do you think it went up to this time? 5%, a little bit more than that. It was 14%. The third group, and perhaps the most intriguing group, went up to the table with a bill and a sweet, just 1 sweet this time, and as they walked away from the table, reached in the pocket, pulled out an additional sweet, and for you, sir, an additional sweet. What percentage increase this time? 23%. How many sweets were given? 2 sweets. What's the difference? It's just not what you say, but how you say it. Exactly that, and felt special. Absolutely. You introduced this next slide perfectly. They felt special. What matters individually? What matters individually to your clients? What matters individually to you guys as a team? How many of you have a list of your clients and alongside them their dates of birth? How do you feel when somebody wishes you happy birthday, even though you know it's popped up on Facebook? Equally so, how do you feel when somebody remembers your name at a conference 3 years down the line? Pretty special, right? Comes back to what's your name say? What's your name? Valdana, it's okay. Okay. Just saying, it comes back to what you said. It makes them feel special. And we can tailor that as well. So often when we reward great work or reward our clients, we might give them a bottle of bubbly or box of chocolates, but what happens if, let's say, Helen is a non-alcoholic, she doesn't drink alcohol, or Steve's a diabetic and doesn't eat chocolates? Far better would be to give something more tailored to make them feel special, like letting Helen leave work 2 hours early because she's a single mum. In fact, we did a piece of market research in the Influence Association where we sent out a load of market research forms to see what motivates people or what rewards they would like outside of financial or holidays. The number 1 thing that came up was a handwritten note from the CEO. Now, I'm not suggesting you handwrite everybody a note. You could do. I don't know how big you guys are here. But think about how that personalization is so important. We saw it before in Joe Girard and Ali Raider, and again here. So, which leads us back to this. And I'm hoping you have thought or drawn a few ideas that you can apply and change or elevate what you thought was the final solution to the experiment we tried before. So I want everybody to stand up, grab that ribbon, lay it down in front of them, face one another again. Everybody stand up. And this time, you're going to do exactly the same. You're going to influence the other person to step over to the other side. And this time, you've only got 1 minute. So once it gets to the end, that is the minute up. Thank you. Okay. You did that last time. That was the same as last time. How can you make that better? How can that be better?
You can see best the screen.
Okay. Okay, guys, thank you. Everybody grab your ribbon, pop it back on the table, and everybody sit down. Everybody grab a sit down again. Everybody pick up the ribbon. Everybody grab a sit down. I just grab the ribbon. Okay. Everybody grab a sit down. Perfect. So, hands up if you're able to do it this time. Hands up if you weren't able to do it. So, some people did exactly the same thing. But I want to give you the secret sauce, how this should actually play out. Hands up if you chose the principle of reciprocity. Yes? Fantastic. You chose? So this is how it works. So often in our minds, we think about winning and losing. I didn't say to any of you, you lose if you step over to the other side. So if we eliminate that from our minds about winning and losing, life becomes a little bit easier. So with the reciprocity piece, you step over to the other side, which many of you did, and that way you add value to them. Because you've added value to them, it's easy for them to step over to the other side. And this way you both win. So it's not about one person winning, it's about both of you winning together. And this is the absolute core to any influence and persuasion. There's a very, well, not famous, but there's a well-known real estate mogul in China. And he always gives away 51% of his company. When he's asked why he gives away 51% of his company, his answer is always the same. That way, everybody wants to work with me. So, concern yourself with the success of others, and everybody wants to work with you. Which leads to the final points: collaboration, communication, and authenticity. And how does this apply to you guys? In a summary, we ask better questions. Better questions lead to better conversations lead to better relationships make life so much easier. Listening with intent. If you change the intent, you can understand their needs. And if you can understand their needs, you serve them better by activating reciprocity first. Deliver authenticity and authority. Focus on the differences as opposed to the similarities through your value proposition. How are you different from everything else and how you can be of benefit? Leverage social proof, what others are already saying or doing about your organization. You're changing the world. Shout about it. Slow down the pace to understand their needs, specific context, to increase that level of trust and then gain consensus, not only for your product or service, but to change. Once they're committed to that change, then you can show the value in how you can service that change. Use stacking for innovational and transformational change with your organization. You're doing such an amazing thing. Why not take it bigger? And lead instead of manage. Whether it's leading within your organization, but leading your clients as well. And finally, understand their needs. If you understand their needs, you can serve them better. Which leads to this. If you collaborate and communicate with somebody, you could say you know them. Communicate with any form of authenticity. it will lead to likability, or authentically collaborate, it leads to trust. And as we know, people do business with those that they know, like, and trust. The final slide is this, my extension to you to collaborate. If everybody opens up their phone and swipes up to the photo or camera, if you scan that in, I will send you a copy of these slides if you want them. And then if you have any other questions as well, it should populate an automatic email. But before we close, I'm hoping we've got time, I think, Tonya, yes, for another quick mentalism? Yes? Are we good for another quick mentalism? Perfect. So, everybody pop their phones down. And this is very important for this part. Perfect. So, I did say I was, this talk is about influence and persuasion. What some of you probably didn't know is that throughout this show I have been trying to influence and persuade you guys into thinking certain things. In 1957, there was a market researcher by the name of James Vickery. James Vickery believed that he could influence people to drink more Coca-Cola and eat more popcorn at the cinema simply by flashing up these words in between the cinema screen as you were watching your movie. According to him, people drank more Coca-Cola and ate more popcorn. He lived this lie for 20, 30 years until it was both debunked and he admitted it was all a hoax. That said, I love the idea. And I also love the idea why when you're in a hot room, somebody yawns and then somebody else yawns as well, and all of a sudden 3 or 4 people are yawning. But equally so, why you find yourself whistling a song that you've heard in the supermarket. I love this idea of subliminal influence. So I've incorporated that into what I've been doing today. So I'm hopefully going to have a little play with that right now. So I'm going to get 7 of you to take part. You don't have to feel like you have to come up. Nobody's coming up, actually. So you can stay in your seats. If you want to take part, I'm going to ask you to put your hands in the air. And if you do take part, you're going to take a card. If you take the card, you're going to print your first and last name along the top. And you're going to think of a word. Any word you want, be as creative as you possibly can, and then change it 3 times. So if you think of rabbit as your first word, you change it to, let's say, microphone, and then maybe skydiver. It will be this final word that you write on here. So your first name, last name, and then a word on here. Does that make sense to everybody? There's one very important rule for this, is that if you fill it out like this or fill it out on the table, I'm not going to use it because people could say, well, I just looked. You have to fill it out like this, and I have to be strict on that because everybody else will just say I looked. Also make sure they're not funny pens, magic pens that are receiving a special code or something to me, which is the first thing that people always think. If you want to take part in this, you don't have to come up. You can stay sat down, put your hands in the air. I've got 7 of these. I'd like to get a mix. Yes, we'll grab one over here. One for you. Yes, go ahead. In English as well, if you could. Because if you use a biro, it will probably mark it. You can do it if you want, but it creates an indentation, but you can do it if you want. It just makes it easier. Excuse me, can I squeeze my hand? It's up to you. It's up to you. I just want to make it fair. Grab one as well. And one over here. Quick as you can. Wait for me to finish walking around the room. Okay, I'll come over to this side. Yes, okay. We got one. I think Tonya had that. I'll tell you what, let's do this. Okay, you guys do that. Don't let me see. Don't worry, we'll do something for you. So guys, fire away. Once you've written your name and first and last name along the top, and this word, turn it face down in your hands. Everybody turn it face down in your hands. Yes. And then I'll come round and collect them up. As I said, don't fill them out on the table. It was the one instruction. It's that listening piece again. Are we good? Yes? Okay. Good stuff. If you put the pen in there, and that in there. Perfect. And the pen as well, please. And the pen as well. Thank you so much. Perfect stuff. If you come in there, if you want to take a pen, if you think you're magic, you have a look. No, honestly. Anybody else? Where are the other cards? We've got one over here. Yeah. And the pen in there. Actually, thank you. Any others? Any others? Any others? And the pen as well, please. Come on. Any others? Yes. Perfect, perfect, perfect. That's in there. And if you take all of the cards, and then if you mix them all up. Perfect. So, Tonya, I saw your hand up. You've arranged all of this, but I think it's only fair if you had a go as well. However, what I need you to do is absolutely stress to everybody we've not set anything up. Be as honest as you can be. We've not set anything up or spoken. You didn't even know this was going to happen. Good. Okay. Perfect. Let me do this then. So what I want you to do is be as creative as you can. You don't have to change your mind 3 times. Change it as many times as you want. And think of it as the most creative random word you can come up with.
Okay.
Yeah?
Okay.
Let me see if I've got any more cards over here. I might have this. Maybe not. No, maybe do that. We'll just do that one. It's okay. We'll do that. Any word in the world. You don't even have to write your name. Everybody knows your name. Yeah. Keep it in the envelope. Go all the way over there, or over the where. Again, just so that people don't think it's a pen. Make sure it's a normal pen. Make sure there's no cameras. And again, if you need to tell these people there's not set anything up, because they will ask you afterwards.
Yeah, no.
Any word. Be as bonkers as you want. As crazy. The more crazy it is, the better. But don't take it out of the envelope. Keep it hidden in the envelope. Keep it hidden there. Mix them all up. You've mixed. You're going to choose one at random. Choose one at random. Keep them face down there. Seal it in the envelope. And then you're going to seal that one in that envelope. Give me the other ones back. Seal that one in the envelope face down. Perfect. If you could seal it in the envelope. Yes. If you could, what's your name again? Give it to Armando.
Okay.
Together with the pen. And then Armando, if you mix them up as well. Mix, mix, mix. I'll have the pen back. Mix, mix, mix. Mix, 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 mix. And then come and sit over on the end chair for us. Give him a round of applause, everybody, as he does that. Come and sit on the chair.
Armando.
On the end chair, on the end chair.
listening.
So you can go and sit down. We'll come to you in a minute. So the mix, if you put them in 2 hands, like that. Perfect. So would we all agree this is completely fair? This is not magic or anything like that. I've given the opportunity to check out the pens. If you want to come and check out the pens after, that's absolutely fair. You filled out these slips of paper. I've not touched them. You've given them to Armando. Armando's chosen one. Yes? You filled out yours and then passed it to Armando. Very clearly, I've not been near that.
Yep.
Yes? So, by a show of hands, hands up, who took part in this? Okay. I didn't collect in? Oh, over here as well. Okay, perfect. Who have we got on this table here? Who took part?
Yeah.
What's your name? Lauren. And your name? Ruth. Okay, I think we'll give it a go for both of yours. Are you there? I would say, what's your nationality? US. I would say for you, based on my over-importance of listening, you may not have listened. I asked you to write 1 word. I would suggest you're the kind of person who probably put 3 words. Is that right? Yes. I would say that you haven't been, because you didn't listen or didn't follow that along, you therefore didn't think about being as creative as you could be. Where were you from, Lauren? The US. I would say you did just put the 1 word and you were creative. You made your words I'd say that for you. Let me go back. Keep it to your chest for a second. Don't look just yet. Don't look. Let's have a look. Your words were reciprocity, value, and bull. So you had 3 words. Admittedly, I only got 2. If you want to turn that around and show everybody. We have authenticity, value, and bull. Let's give a big clap. Perfect stuff. So let's go for yours. Yours. Hopefully, I was trying to influence you specifically. How many times did you change your mind?
Oh, she didn't.
So this is the first word of the three that you didn't change to. This was one of the words. Let's hope it was the word you picked up on as your first word. What was the word you plucked out of the air? Yeah, go ahead. Absolutely. Cookies. I think we should give Lauren a massive clap over. Here's the word cookies. Look at that. Which leads, Tanya, leads us yours. Leads us your word. So you were as creative as possible. You didn't just think of authenticity, ball, or anything like that. You just went creative. Yeah? Good. I would say I tried to get you to go for 2 words. I think you might have settled on this one because of your position, because of your passion for this company. I think it's passion related. Out loud, and just for Lauren, we've not set anything up.
No.
Out loud, what was the word you were thinking of?
Thrive.
Thrive. Let's give a massive clap. Let's give a massive clap, everybody. Thanks so much for Monday. Perfect stuff. Perfect. So, guys, that is the end of my little speech. I hope you've enjoyed it. I hope you've enjoyed the content. Thanks so much for having us. Thanks so much.
That's crazy. Woo!
Thank you. Thanks so much. You're very welcome.
That is just amazing. Thank you so much, Duncan.
My
that
pleasure.
was really fantastic. I hope that you guys enjoyed it as much as I did. It is the. Can we get me up? Okay.
Excuse me, Duncan, but where is the advocacy in it? Why are you finding all these things?
Because I'm about to bring it together for you. Am I good? No? Okay. So Duncan and I we had one conversation over the phone. It was just about who this group is, what do we do, and why we wanted to talk about influence, period. It was 10 minutes.
Yeah.
I had not done any of my slides. I knew nothing that he was I had only seen like a video clip of him that was 2 to 3 minutes long. And then 1 10-minute conversation about who GAAPP is and what we do. And, that we have the desire to influence patient behavior, provider behavior, and policymaker behavior. That's all he knew coming into this. That we were a group of passionate advocates who had the desire to influence in order to change the world that we live in. And so I think that so much of what he brought to light feeds into the couple of last slides and comments that I want to make this afternoon. We have had great success at GAAPP over the last 5-10 years. We could easily focus on the things of where, how far we've come and the progress we've made and pat ourselves on the back and all go home and do, continue doing the same thing we've always done. And each of you in your own respects and your own organizations have made great progress and strides. But it's also been a very difficult 2.5 years. And I've had numerous conversations with people in this room about the challenges of the last 2 years, about the fear of, can we make a difference? Can our organization survive? Where's the money going to come from? How do I pay my people when everybody's cutting back? How do we, transition to a remote working environment? How do we stay connected globally when we can't come together? And when we are stretched beyond the possible means personally and professionally that we ever thought we would be. I don't know a single person in this room who has not experienced tremendous loss, challenge, and just, adversity over the last 2 or 3 years. There's not a single one of us that has not had that experience. And so we have a choice. In the next slide, actually, shows a bit about the way that I have changed my mindset in thinking about this. This is from a book called The GAAPP or Gain, The GAAPP and the Gain. And so when in our brains, when we're thinking about our experiences and life and the things we're going through, oftentimes we all have this starting point, right? And we can either compare that to the ideal of what the perfect world would be, what we wish it would be, and see ourselves as in the gap. Well, when I do this, when we get there, when the organization gets $1 million in its reserve, when this happens, when that happens, when, if, right? Or I wish I only had this person's talents, or I only wish I had this person. If only I was in this region or the world or this area. If only this, if only that, right? That's a gap mentality. Always looking at or feeling like a failure. Always feeling like we don't measure up. Being frustrated, disappointed, really down on ourselves at times, right? We all can get there. I'm not sure that there's a person in the room who can't say that in the last 2.5 years of the pandemic, you haven't at some point found yourself in the gap. Can everybody relate to that? I will tell you, I have definitely found myself there from time to time. And yet, this second way that we can look at the same situations is to look at the starting point, not necessarily compare ourselves to the ideal, but visualize where we want to go, and instead measure backwards. Think about what we've achieved. So while I'm not my ideal weight, I am 10 pounds closer. While I may not have achieved all of my financial goals, I've achieved some of them, and I'm moving in this direction. These are the actions I'm taking. While I may not have ever achieved the 0 deaths due to asthma that is my ideal, I know that the actions that our organization is taking, the work we're doing, is reducing that mortality rate every day, and we measure that. So measuring the progress gives me a different mindset. I'm focused on the successes. I'm much more satisfied. I'm much more confident in what I'm doing because I realize how far we have come, right? It leads to higher self-esteem. It leads to greater enjoyment and certainly more optimism. In my life, what it has done over the last really year that I have changed this from, and I would say somewhat at the beginning of the pandemic, it's allowed me to move from being bitter about all the things we lost to being better. It's allowed me to stop thinking I have to be perfect and realizing that if we're just making progress, and sorry for the emotion, but this has been an emotional 3 years. If we just keep making progress towards the goals, we're at least better off than where we started. It's allowed me to move from being so caught up in the extrinsic and external motivations of this world, whether that's money or status or, for some people it's a car or a house or whatever that external thing is that motivates you, to being more internally motivated, to saying, I'm going to do what I'm going to do because it's the right thing for me. It is fulfilling the calling on my life. To move from comparison to compliments for myself. So, social media is great, and we use it so much in our organizations, and yet I've watched how it can be so detrimental to comparing and saying, oh, I wish I lived that life, or I wish I had this, or, I look at my teenagers and young adults and that price of comparison that comes from social media. And if you change from that, oh, I wish I was this influencer GAAPP mindset, which, by the way, doesn't really exist because that's an ideal that no one lives up to. I try to tell them all the time. To more of complimenting myself and thinking about, well, this is how far I've come. right? And I've done better, and I'm making steps. It's moving from a passive way of life, of all of this is happening to me and I have zero influence or control, to actively owning what I can do. Because there's so much that we can't do. But if we focus on the gain rather than the gap, of the have-nots versus the haves, of where we are today, here versus there, when we get there, then again, it makes the journey so much more enjoyable. And for me, it has been moving from trauma in my life, which we all have to some degree, to reframing that of transformation. If that trauma had not happened, if we had not lost loved ones during the pandemic, if we had not suffered financial loss of our organizations, if we had not seen the world come to a halt, what is the transformation that would not have happened? And I'll tell you what it is for our community. We would not be standing on the precipice of the day that we come together and say we can transform the world. We can change the way that lung health is prioritized. I look at what's happened, and you know, in some ways, one of the best blessings of recentering me on what's most important. For me, that's my faith. It's my family. It's my friends. And it is the work, the calling of this organization. Many of you don't know, I have decided to, thanks. Thank you, Susanna. I have decided to step down from my role at Allergy and Asthma Network after 10 years of leading there. And that was a very, very hard decision to make because I love the work that I do. But I felt that it was time for the organization to go in a different direction. And to be honest, I felt compelled to focus more on the global work. And I don't have the capacity to do that. And so, you know, I wanted to share some of this with you all today because I have 2 years left in my time with you as your president of GAAPP. My term is 2 more years. And what I vow to you is that over the next 2 years, I'm going to do my damnedest to be in this gain mindset every day, to look at how far we've come, to certainly have those ideals and the goals and the aims and all the things we've talked about here today, but to effectively lead from a gain mindset instead of a gap mindset so that we can thrive. Which, again, crazy. I did not know this. We did not have this conversation. You know, over the last 2 years, we've been in what I call oftentimes kind of that survival mindset, right? But when we're in the survive mode, it's that fight or flight, right? We have a laser focus. We're focused on solving the problem. We have to get through. You know, oftentimes there's fear and anxiety behind that. That's that fight or flight survive mode. And we become very reactive, right? And what I have consciously been trying to do is think about how do I change from the last 2.5 years of a survival mode to a thrive mode, to where I don't see these things as threats, I see them as opportunities. I see the way that this broadens our mission and our perspective as a team, as a group of advocates, where I feel more energy towards the mission and the goals rather than the burden of the job at hand, and where I face that not with fear and anxiety about tomorrow, but with passion and excitement about tomorrow. And really, the behaviors of this thrive mode is innovation and collaboration. And again, he didn't see this, had no idea. But if we go to that point of getting out of fight or flight, survive mode to thrive mode, we will create new, innovative, collaborative ways of advancing the mission and creating a world without atopic and airways diseases. We will do that because we'll begin to see those opportunities. And this is John Cotter's sort of successful change. How do we create that change? Today we've talked so much about changes that we would like to see and where those barriers are and how do we change that. Well, this is how John Cotter suggests that we do that. First, it's establish a sense of urgency. I hope that you feel that today, that we are sitting here saying there will never be a moment in time like this moment in time. We won't have this opportunity again. Second, create a guiding coalition. That is the people in this room. It is patient advocates, it is healthcare professionals, it is industry, it is people who live on passion for this community that we serve. It's developing a very clear shared vision and getting us all on the same page around that vision and communicating that vision effectively, as we heard about in the influence discussion. And then it's empowering you to act on that vision, because the truth is, this is a volunteer organization, right? I don't employ anyone in this room. I can't force you to do anything. So how do we support and empower you to achieve the vision and the mission that we've set forth? How do we create those short-term wins? I loved when you said that, because I immediately thought in our breakout earlier, I thought, we're on the right track, we're on the same page. If we can create some very short-term wins through things like the IRC, the International Respiratory Coalition, through things like the ERS having 5, 6 patient speakers this year when they didn't have any 2 years ago, 3 years ago, what can we do in the next 5 years? What if, in the next 5 years we set a goal of having 20 patient speakers, right? Or every symposium having a patient voice. There's so many ways that we can actually create those short-term wins and momentum around the goals. And then consolidate and build on the gains. Keeping that gain mindset, certainly building as stacking, as we talked about earlier. That's what it is. It's getting one win and another win and another win. And before you know it, we're a group of over 80 advocates. That's how it's worked and how it will continue to. And then institutionalizing the change. And so, I just want to be honest with you guys that it's been a difficult 2 or 3 years. I looked forward to the day when we would be back in a room physically together, because I know that there's something that happens in the energy and networking and organic, what's going to happen tonight as we celebrate, that can't happen in the square box of Zoom. And so thank you for going on this journey. Thank you for committing to be here. And thank you for standing with me at this precipice and saying, now is the time. We will do the work. We will stay focused on the gain mindset and thrive rather than just survive. That's the opportunity that we have of working together. That's the power of a group like Global Allergy and Airways Patient Platform. And again, not me, not Victor and Lindsay, as great as they are, not the board, it's all of us. And so I just want to encourage you guys that we are here. We will stay committed to this and accountable to it in the coming days. And now we can go have a great time tonight and celebrate. And, I think that the future of GAAPP is very bright. When I think about what we will be in another few years, I see over 100 organizations sitting around this room. I see us as the absolute go-to global leader. When there is a conversation about immunology or respiratory, there is no other discussion about, are we going to have a global participant? Yes, that's GAAPP. I see us continuing on the guidelines, but expanding that. The atopic dermatitis guidelines, the chronic urticaria guidelines. There are so many other ways that we can have that voice. I see us as a very key awareness and media voice throughout the world in these spaces. I see the opportunity to have the patient engagement in research and development at every single stage, everywhere in the world. Nothing annoys me worse than the fact that I can get patients involved in research in designing a clinical trial in the US, and I can't do that in other parts of the world. And that clinical trials aren't representative of people all over the world. So this is a commitment that I have to you. The other future I see for GAAPP, and that we as a board have discussed, is the day when we'll be able to fund $1 million a year to our member organizations, where we'll be able to say, you know, perhaps we can fund more than the 25% that we're doing right now of a project, or that you guys are doing projects of such scale and scope that 25% is greater than $1 million. That's the goal that I have. And then that we continue to remain financially stable. When I came here and began to lead in 2017, most of you know, definitely our board knows, we had $0. $0. Not a penny to really operate or to grow the organization or to employ staff. 0. Today, we are close to $1 million in revenue and have a reserve of over $500,000. And that, not to say that money is everything, but it takes those resources to do the kind of work that we're talking about. And again, we are this far into it. We've got this far to go. So I know we're going to be able to do that together. Again, I can't thank you enough for making the effort, for being here. We look forward to just a rock star year of working together.